Okay. A very good evening to all of you and wishing you a very very happy new year since we are beginning this class in is the first class of 2026. So I hope you succeed in all your exams. So let's begin with the rapid revision session. So I know that you all are waiting for this doctor name in front of you to be written. So I hope that this session turns out to be really great for you, and I wish. Okay, so as I was telling you that giving you lots of good luck for your exam, I just want to begin this new year with lots of hopes and wishes for you all. So let us begin with nutrition because this is a topic where from which place almost 2 to 3 questions are like short in every exam. So this is a must know topic. So nutrition can be divided into macro and micronutrients. This is the first thing you should be knowing. In macronutrients, we have our proteins, carbohydrates, and fats, so which we take daily in our diet. Okay, but our main focus will be on vitamins because this is the hot favorite MCQ topic for all the exams. So the micronutrients, which are why they are micro because they are not required in gram, but in the lesser quantity that is milligram or micrograms. So vitamins particularly can be divided into fat soluble vitamins. So I expect you all that you must be knowing what are all the fat soluble vitamins. Anyone in the comment box? I'm reading your answers. So vitamin Am I audible to you all? Because I can see that there are a few people who are saying that voice was gone. Okay, ADEK. Everyone knows about it. Vitamin A, D, E, K. These are all the fat soluble vitamins, whereas the water soluble ones can be divided into the B complex one and the non B complexes. So, in B complex, we have energy releasing vitamins and hematopoietic and others. So, let us first talk and finish like vitamin C and vitamin B6 are the other vitamins, while the hematopoietic ones are vitamin B9, which is also called as your folate, right? And your vitamin B12, also called as, yes, anyone? The cobalamin, okay? And the energy releasing vitamins we are your vitamin B1, your vitamin B2, your vitamin B3, your vitamin again B7, and that is all, B5, right? So these are all our energy releasing vitamins. Apart from this was also asked in one of your FMG's questions related to calcium, that this is a mineral, okay, and it is a micronutrient. That is something you should be knowing. So calcium, phosphorus, sodium, magnesium, potassium, and chloride are your macro minerals among the minerals, and the micro minerals are copper, iron, zinc, manganese, and fluoride. Then we have also ultra trace minerals like selenium, which is also a very good antioxidant, molybdenum, iodine, and chromium. Okay, so this is one classification which you just have to be aware, and specifically this calcium was asked in the question as well. Then let us start discussing with the fat soluble group first. Your vitamin A being the first vitamin, so the role of vitamin A is in the vision. First thing you should be knowing. So I would like to tell you that since it is a rapid revision class, we will not be focusing much on the names, chemical names of vitamins, because that's not asked. So mainly the deficiency we will be discussing. Apart from this, you should be knowing that if it is a fat soluble vitamin, okay, so if the question is giving you a certain condition, will you be able to diagnose that this particular vitamin is deficient? That is something where you should focus more rather than learning a lot of chemistry part of vitamins. Okay, so the fat soluble vitamins or will be deficient in all those people which have malabsorption syndrome. So if sometimes they give a clinical history of malabsorption, that time you think of any vitamin A, D, E, or K deficiency, also depending on what other symptoms will be given. So I would like, yeah, everyone is already answering. I can see Saurabh is night blindness, by dot spot, everything you already know. I know, and it's really great. And we are here to revise itself. Fine. So the vision, the Waltz visual cycle, that is where your vitamin A is important. Then the regulation of gene expression is one of the functions of vitamin A. It also plays role in your normal reproduction and maintenance of normal epithelium of skin and mucosa. So if you remember in dermatology, we also discussed the skin condition which was happening. Anyone who can tell that uh, because of deficiency of vitamin A. Also remember that this is also one of the antioxidants. So you should be knowing all vitamins which plays role in antioxidation function as well. Therapeutic use also we discussed in dermatology, that isotretinoin is a drug which is a form of vitamin A. The 13 cis retinoic acid, you don't need to remember the form, but you need to know that it can be used in treatment of acne. Then the sources, halibut liver oil is one of the source. Carrots, I think all of you know about carrots, right? It is the richest source. Then the green leafy vegetables and animal sources like egg, milk, fish, and meat are there. So, as everyone is already answering in the comment section, nyctalopia deficiency. If vitamin A gets deficient, what will you have is a night blindness. Why this is happening? Because vitamin A is having a role in dark adaptation. So, you must have observed that whenever you come from light outside from sunlight into a dark room, it takes some time for your eyes to settle down, and this is called as the dark adaptation time. So this is done by a pigment rhodopsin. You must be aware of it. So if vitamin A goes deficient, this is the thing which will be affected, and night blindness will be the first symptom which will be happening. Actually, it is not the first symptom. Actually, the green color uh, will not be visualized by the patient, but this is something which patient will not come with this complaint that I can't see the green color. He will not be able to identify. Only what a patient who is going to come is the uh, night blindness. So that is something which is important for you to remember. Then we have a corneal xerosis, the dryness of the cornea, which is happening because of the vitamin A deficiency. Defines as night. Phrynoderma sorub, absolutely right, is the right answer for skin condition. Then we have Bitot spot. So this second image is showing your Bitot spot, and this is a sometimes it is already asked as have already asked been like a image based question, and this is the corneal xerosis which is shown. Okay, and the last one is your corneal ulcer which can happen, as you can see. So if mainly the eye manifestations are important, so this is all going to happen. And follicular hyperkeratosis, that is phrynoderma, as Saurabh said, and squamous metaplasia will be the deficiency disorders of skin. Then if there is a toxicity, see, because it is a fat soluble vitamin, toxicity can also happen. So there is a condition which is called as pseudo tumor cerebri. So it is the name itself is already telling that it is pseudo condition. So it apparently it feels like that there is a tumor in the brain, but it is not actually tumor. It is just a raise in intracranial hypertension. Okay, so because of this, the symptoms like visual disturbances, that will probably given in the question, and that can help you make the diagnosis of acute toxicity if it is going to happen. Chronic toxicity might happen, but majorly the questions are asked on the deficiency disorders only. So bony exhaustosis, hepatomegaly, if it is chronic only can happen. And remember, we had already discussed this as well, that it is a teratogenic. If isotretinoin is given or vitamin A is given in pregnancy, that is teratogenic. So that's why we avoid it in pregnancy. Then we now move on to vitamin D. So vitamin D is something which everyone knows. It has a major role in regulation of calcium and phosphate. So absorption of calcium is something from intestine, and reabsorption from kidney is majorly taken care by our vitamin D. Along with that, it also takes care of phosphate, because vitamin D is needed for making your bones strong, right? Then in COVID times, you might have heard about that vitamin D supplementation. So there are studies also which shows that vitamin D levels in patients who had good levels of vitamin D could recover well in COVID as well. So that is why it has immunomodulatory function as well. And patients who have enough good levels of vitamin D can we can see that it prevents from tuberculosis as well. So I hope everyone is keeping up the pace. I hope the audio, visual, everything is good to all. I'm not hearing any answers. And it has anti-proliferative actions also. So it prevents cancer of colon, breast, prostate, etc. So you all know that vitamin D we can't take it from outside. This is the sunshine vitamin. So whenever we sit under the sun, so skin helps in synthesis of vitamin D, and that is why sources of vitamin D are not of any importance, because you have to still get it from sunlight, or otherwise you can just take the supplements. Okay, anything which is fortified food, if you're putting vitamin D externally in that, then you can have it. Fish, a little amount of vitamin D is also there in fish. So now what if the deficiency occurs? Very, very important, has been asked previously about rickets, that because it is helping in the absorption and reabsorption of vitamin D. Now, if there is not availability of vitamin D, what happens is rickets condition, vitamin D deficiency, before closure of epiphysis. So that means if it is occurring in children, if the vitamin D deficiency is occurring in children, the children will have rickets. And if it is happening in adults, the patient will have osteomalacia. So osteo word is for bones and malacia is for weakness, right? So that is going to happen in adults, and rickets is going to happen in the children. So the condition like this rickets what will be manifested as the genu valgum and verum, these deformities which you can see and you also study in ortho. Then there is wind swept deformity which is seen here. And apart from this, these are called as, this beaded appearance is called as rachitic, okay, rosary. Then if there happens toxicity of vitamin D. Now you know that vitamin D is helping in absorption of calcium, right? So if it is absorbing more and more calcium, this excess calcium can go and sit in the blood vessels and deposit there, and this condition is called as calcinosis. So if there is a toxicity of vitamin D, calcinosis can happen. So I'll be focusing mostly on the important points, and because this is an RR session and you have to trust on this that the questions will be coming from this part only. Most of the things are not asked related to direct chemistry, but the clinical implications are asked in the current pattern of exam, right? So we have now, we need to read about vitamin E and vitamin K. So vitamin E is the most potent antioxidant. So one antioxidant we have already read. Can anyone tell me which was that vitamin? Okay, doxam. It's not about taking a long sessions. Basically, we have to include all those things which can be asked in the exam. So 3 hours for derma is fine, and the class for biochemistry will be around something 4 hours. Okay, so we have to still cover all those which can be asked, and the current pattern of FMG exam is changing, and a lot of clinical questions are asked. So you have to be thorough in your subject. But this will be included, or everything will be included. Vitamin A, Dr. Nova, and Jadharan Buva Divalan, whatever it is. Sorry if I incorrectly pronounced it. Okay, so another function of vitamin E apart from antioxidant, as you also know that vitamin A is also one of the antioxidant vitamin. It prevents LDL oxidation. Now what happens is low density lipoprotein. Okay, so this is LDL. Please correct in the PDF that it prevents LDL oxidation. What happens if LDL gets oxidized? It is going to cause atherosclerosis. So now if vitamin E is sufficient, then it will not cause oxidation of LDL. So atherosclerosis will not happen. So that is the thing. And it protects polyunsaturated fatty acids and membrane from lipid peroxidation. Same thing. Okay. And we can also use it as a therapeutic usage is also there in retrolental fibroplasia, intermittent claudication, bronchopulmonary dysplasia, and intraventricular hemorrhage. And it slows your aging because it is also having antioxidation function, and it prevents fatty liver. But what is more important is the deficiency. Okay, so in the neurons, it prevents, if there is a deficiency of vitamin A, there will be axonal degeneration, and the patient will be presented with neuropathy. So peripheral neuropathy signs will be given in the question. So you should be able to make the diagnosis. Then we can have spinocerebral ataxia in its deficiency and hemolytic anemia. So there are certain eye manifestation which is going to happen. Pigmentary retinopathy will be there, ophthalmoplegia and nystagmus in vitamin E deficiency. So it also interferes with platelet tox aggregation if there is a toxicity of vitamin E. So toxicity is not that important. Okay, so I will suggest you to read more and remember more about the deficiency. And then we move to the vitamin K, and functions of vitamin K is very important. So since this has been asked already, post translational gamma carboxylation. So this is a reaction, okay, which is something you all should be knowing that it does gamma carboxylation of which substances? Prothrombin, okay, basically learn it like that: factor 2, 7, 9, and 10. Okay, this is how you should remember. So, post translational gamma carboxylation of your clotting factors 2, 7, 9, and 10 is done by your vitamin K. Okay. And then there are other things which are your calcins, nephrocalcin and osteocalcin, which are less important in comparison to the factors. And then we have a protein C and S. Okay. And then there is a gene which is GAS6 gene. Its product also needs to undergo this reaction of gamma carboxylation. So there also vitamin K is required. But again, I would like you to focus on the factors 2, 7, 9, and 10 because they have been asked previously. And the name of the reaction, the post translational gamma carboxylation, is something you should be remembering. Okay. And then just related to this, we can also use vitamin K. Epoxidase is the enzyme which is going to bring back vitamin K8 into the normal state. So this is going to inhibit this warfarin and decumerol, which are anticoagulant drugs which can be used. They are going to inhibit epoxidase enzyme, and that is how we can use in the treatment. Okay. So this is all about vitamin K. And apart from this, the deficiency, the functions which we discussed were important, specifically related to the clotting factors. And now we move to the deficiency disorders. So the bleeding manifestations, obviously, if it is helping to, make your clotting factors, if it goes deficient, then the bleeding manifestation are going to happen. So if you see that there will be bleeding manifestation, then your clotting time and prothrombin time, what is going to happen with your clotting time and prothrombin time? Anyone? So vitamin K is not there. It is going to increase. Okay. Logically, put some logic also. Not always what's written is correct. Right? Yes, Saurabh, you're correct. Vignesh as well. So what happens is vitamin K is also synthesized in intestine by your microflora. Okay. So if your microflora synthesizes your vitamin K, whenever there is a premature baby who's born, his gut flora is not mature. So that is why he will be deficient in vitamin K. And this makes it essential for us to give injection of vitamin K at birth, specifically in premature babies. Okay. If the toxicity happen, then hemolysis is going to happen, which is going to lead to hyperbilirubinemia, causing kernicterus, because the babies are prone for kernicterus because of what? Anyone who can answer? Yes, Saurabh correctly said the gut flora is not developed in the babies. Yes, injection is given to the newborn. Also, apart from this, that their gut flora is not maintained, the breast milk, so the infants are on breast milk, they are not eating any other food, right? So this has also been asked, that breast milk is a poor source of vitamin K. Now can we move to the vitamin B complex, starting with the hematopoietic vitamins, very very important again. So, your vitamin B9. Let us start with vitamin B9, your folic acid. Why folic? Name comes from folium. Okay, so this is because of your leaves. So, the source of B9 is green leafy vegetables, and that is why the name is given as folium. Okay, folic acid. So, this is important because it is the active form is tetrahydrofolic acid, and it is a carrier of one carbon group. So there are certain chemical groups like formyl, okay, formyl, methyl. So these are all involved in various metabolic pathways. If they are involved in metabolic pathways, then obviously we need vitamin B9 for different chemical reactions in bodies. We don't have to learn all the reactions because direct reactions are not asked in the exam. Now, these reactions also helps in synthesis of DNA. And because of this, if deficiency of B9 occurs, then what happens is megaloblastic anemia. So the deficiency manifestation, which is important, is megaloblastic anemia. So they can also give you a histopathological image of megaloblastic anemia, and you should be able to diagnose it with the deficiency this manifestation given in the question. If also you might have heard that this vitamin B9 has to be taken in, like for the pregnant females it is important, because if they get deficient in vitamin B9, the baby will have neural tube defects, which is spina bifida and anencephaly. So this is also important, so they can also, yes Saurabh, you're correctly said. Then we have homocystinemia. Why? Because again, this happens because of defect in sulfur containing amino acid metabolism. Okay. So if this goes defective, what is going to happen? Your homocysteine ideally should be converted back to methionine. So if there is deficiency, it will not be converted to methionine. Okay. So if methionine is not there, then SAM, which is your, anyone, your methyl donor, it is your primary methyl donor, which is required in various metabolic pathways and also in epigenetic modifications. Okay, so we don't need to go into the depth of each and every pathway in rapid revision session. Okay, because what is important for exam, just pick the one liners. Methionine, absolutely right. Okay, Kirtik, this session will be useful for you as well. We can discuss about it later on. Right now, the exam going students need to be more focused, so we can discuss it later on. Okay, so homocystinemia is going to happen in the deficiency of vitamin B9. Okay, then we have to discuss about vitamin B12 and the assessment. I guess some serum level someone is writing, that is also not required for your exam. Mostly you have to focus more on the deficiency manifestations, which will help you to make the diagnosis. Figlu and everything, mostly they will, we will also discuss the questions, so you will be having a clear idea on what kind of questions are asked in the exam. Then we have vitamin B12 deficiency. Now, B12 deficiency is also going to have megaloblastic anemia. Okay, so we will discuss about the functions of vitamin B12 later on. First, I would like you to differentiate it between the deficiency manifestations of B9. Okay, so megaloblastic anemia is something which is going to happen in vitamin B9 as well and vitamin B12 as well. So, what is going to make a differential is your neuro symptoms. Okay, so if you can see, if the patient is saying that he or she is having numbness or loss of reflex, okay, these kind of neuropathy symptoms are there, which are because of subacute combined degeneration. That is the case of vitamin B12, which is not going to happen in vitamin B9. So this is going to help you to differentiate the diagnosis between deficiency of vitamin B9 to vitamin B12. Okay, apart from this, first thing is manifestation. Second thing is what the patient is probably eating. Now, if they are saying that green leafy vegetables are the only source of vitamin B9, so if there is a person who is only a strict non-vegetarian diet, is the person is taking only non-vegetarian food, so will he be able to get vitamin B9? No, right? So he will be having deficiency of vitamin B9. So this is less likely. We don't see such people. But if a person is just eating non-vegetarian food and they also give you a history of megaloblastic anemia, then you think of vitamin B9 deficiency. On the other hand, if the patient is said to have the neuro symptoms as well, like your numbness, loss of reflex, and peripheral neuropathy, along with that, they give you a history of, because it is animal source. Okay, so if patient is a strict vegan, okay, this is a pure strict vegetarianism where the patient is also not taking milk products. Okay, this strict vegan diet, which is certainly in trend these days, is something which is making people prone for vitamin B12 deficiency. So this is Saurabh is correctly saying this, that B12 strict vegan diet is also going to cause B12 deficiency. So if strict non-vegetarian diet, B9 deficiency. If strict vegan diet, then B12 deficiency. Obviously, you have to look at the symptoms as well. Then only you can make the diagnosis. Then the functions, so the reactions, the form of vitamin B12, which is adenosyl B12, is going to perform this reaction methyl malonyl coenzyme A to succinyl coenzyme A. Again, you don't have to remember the reaction, just to make you clear about the differences between the two. I'm just telling you the reactions. Okay, and then this formation of methionine is something which is actually going to be happening because of both vitamin B12 and B9. So any diagnosis if you want to make on the behalf of methionine is not going to help you with the differential in B9 and B12. So again, I will just suggest you to pick the major hints, which are going to help you to answer an exam. So whatever I've highlighted and star marked is something which is going to help you make the diagnosis. Okay. So this is something which you have to just read a day before exam. So here, as we said, causes, here I said again, the non-vegetarian diet is going to cause issues with B9. Okay. And then the nutritional, gastric, or intestinal causes in B12, the vegan diet. Okay. And if the intrinsic factor is less, okay, intrinsic factor is what is produced by the parietal cells. Now, if the intrinsic factor is not produced sufficiently, if there is a decrease in intrinsic factor because of either autoimmune conditions and gastrectomy. So this gastrectomy was given in a question that patient had undergone through a surgery of gastrectomy, and after that the patient presented with peripheral neuropathy. So what could it be? So it was a B12 condition. So you should be able to focus on causes. You should be able to diagnose it in the basis of both of the two things given right here in front of you. Okay, then we have intestinal causes, like Crohn's disease is also one thing where, because if there is some issue with the intestine, the absorption is affected. Okay, and in the metabolism of vitamin B12, your intrinsic factors also involved. So that is why all the three things are very important. Okay, fish tapeworm, if this has also been asked previously in one of the exam, that the fish tapeworm, also called as Diphyllobothrium latum, so this fish tapeworm is already sitting in your intestine, and he loves to eat all the vitamin B12. So probably you are taking it in diet, but it is going to the fish tapeworm and not to you. So this is one other condition which is going to cause vitamin B12 deficiency. And the last one is the stagnant loop syndrome. So this is all about B9 and B12, and we'll be mainly focusing on what is important and useful for your exam. Okay, then we have thiamine. Okay, so see the name itself, one is saying vitamin B9. Okay, B1. And then we have riboflavin is your vitamin B2. So heat stability is not going to be very important for you. Now, what is the source of vitamin B1? First thing. So if you have seen, you must be eating rice or other grains. So the aileron, the brownish layer of the grains, the outer covering, is the place where B1 is. This is the richest area of B1. Okay, so this is present in the aileron layer of grains. Okay, egg and meat is also rich in vitamin B1. Now, let us discuss about the causes of deficiency, because we saw that aileron layer contains vitamin B1. If you do the polishing of rice, if the rice is polished and you are eating polished rice, that means you are removing the upper aileron layer. So in polishing of rice, it gets destroyed. The B1 part is getting destroyed, and you will have deficiency of vitamin B1. So this is something which you have to remember. And chronic alcoholism, I think every exam going student is aware of it, because it actually decreases the absorption of vitamin B1. Are you all with me? Yes, B1, this has also been asked previously. The polished rice consumption is something which is going to cause vitamin B1 deficiency. Fine. So you're all. I hope that you will be able to make a diagnosis. If a question comes and they talk about chronic alcoholic patient, then you also think about vitamin B1. If they give a history of consumption of polished rice, then also you think of vitamin B1. Then what are the features? So the coenzyme role. Okay, your thiamine pyrophosphate, the active form of vitamin B, has a coenzyme role in oxidative decarboxylation reaction, and the enzymes related to it are pyruvate dehydrogenase, branch chain ketodehydrogenase, and alpha ketoglutarate dehydrogenase. Are you all clear with this? Then the deficiency manifestations disorders. So anyone, I guess you're coming for a revision session, so you have to revise with me. Dry beriberi. Anyone who can tell? Dry beriberi is going to DN. Okay, D2N. The neurological symptoms are majorly going to be happening in dry beriberi. So symmetrical motor and sensory neuropathy. Wernicke's is later on we'll see, but let's discuss about the dry beriberi first. The loss of reflexes and muscle atrophy. So if vitamin B1 deficiency happens, dry beriberi is one thing where most of the neurological symptoms will be happening. Then apart from this, wet beriberi, this is related to the cardiac functions. Okay, so the symptoms like dyspnea, cardiomegaly, pulmonary edema, and high output cardiac failure. So basically you look for dyspnea, you look for peripheral edema. So if these are given, then it is going to point towards a wet beriberi. Then, as the students were saying in the comment section, Wernicke's encephalopathy, the CNS involvement again. So this is having nystagmus, ophthalmoplegia, ataxia, and confusion. Okay, so this is mostly they give history related to the chronic alcoholic patient only. Okay, then we have last to discuss is the Wernicke's-Korsakoff syndrome and vitamin B1 deficiency. This is having all the features of Wernicke's encephalopathy, that is your nystagmus, ophthalmoplegia, etc. Along with this, the patient will be having dementia. He will be talking, absurd behavior will be shown. He will be confused. He will be psychotic. So you look for all of this, and this will be also in the deficiency of vitamin B1. Okay, then we have to discuss about vitamin B2. So the important thing for this, the yellow enzyme, is that the coenzymes, okay, it is used, the active form is FAD and FMN. So this FAD and FMN is used in various enzymes like acyl CoA dehydrogenase enzyme, succinate dehydrogenase enzyme. So focus on this, that FAD is used in these two. If you can see, this is D, okay, the acyl CoA and succinate dehydrogenase, because I'm going to shortly ask you this. So you have to remember this. And then the FMN is involved in the complex one of the electron transport chain. Fine. So what is the cause of deficiency of vitamin B2? The poor dietary intake. Okay, and the beefy red magenta tongue, which you can see. Sometimes they can also give you image, or they can just show you the angular stomatitis or cheilitis in patients. So these are the deficiency manifestations of vitamin B2. Okay. Confabulation, yeah, confabulatory psychosis is something which is going to happen in Wernicke-Korsakoff syndrome. Now, apart from this, the cornea is avascular, right? So cornea is avascular, but if there is happening a deficiency of vitamin B2, you can see that there are these, red color blood vessels which can be seen. Okay, so this is corneal vascularization which can happen in patients of vitamin B2 deficiency. So this is of course going to cause difficulty in vision and Okay, apart from this, the lacrimation is also one of the deficiency symptom. Now, toxicity is not important for these because these are water soluble vitamins. So even if you're taking excess in diet, it will be just passed out through the urine. Then we have to discuss about the vitamin B3, okay, the niacin. So now niacin, the important thing is NAD. Okay, so the coenzyme role of vitamin B3, the NAD form is going to, so this correct this. This is not O, this is the D. Okay, so all the dehydrogenases, they use NAD as its coenzyme, except the two which we just discussed in what did we discuss? I said I'll be asking it shortly. The acyl CoA dehydrogenase and succinate dehydrogenase. So, what is going to be used as a coenzyme in both of these enzymes? Anyone? Yes, Dr. Expedition, you're right. So, B12. Anyone else? We just discussed it. C. The FAD, acyl CoA dehydrogenase, and succinate dehydrogenase. So, you have to remember that uh, all the dehydrogenase will be using coenzyme NAD as its coenzyme except for acyl CoA and SDH, your succinate dehydrogenase, where FAD will be used. Okay. Then apart from this, NADPH generation. So all the enzymes where NADPH will be generated. So you know that HMP pathway. So you must be having some idea that HMP pathway is just done to generate NADPH. So if NADPH is released or generated in this pathway, then this must be using the NADPH form of vitamin B3. Okay, and your isocitrate dehydrogenase as well, and malic enzyme. So these are all related to the generation of NADPH. And then wherever NADPH is used, okay, wherever it is consumed, and those enzymes are all the reductases. So wherever you see reductases, so after vitamins we'll be studying about enzymes, so you'll be having a better idea again. And what is the therapeutic use of niacin? We will also study it in lipids, that it is also used as lipid modifying drug. So it helps in the treatment of hypertriglyceridemia. So you can also give, so this also comes in your pharmacology. I hope you have read it yesterday. Okay, so hypertriglyceridemia is something which you will be able to treat with vitamin B3. Then we discuss vitamin B5. Okay, this deficiency, we just left the deficiency and toxicity. Okay, so vitamin B3 deficiency disorder is very important. This image based question has been asked a couple of times. It causes pellagra. Okay, so pellagra is something which is going to be presented as these 4Ds, the dermatitis. And this is a particular type of dermatitis, which is your photosensitive dermatitis. So the patient will be having this rash on the sun exposed area, which is called as Casal's necklace. Okay, and diarrhea, dementia, this kind of a severe diarrhea, that patient will ultimately die. Okay, so these are the 4Ds of pellagra. And apart from this, what happens is there is pellagra like symptoms which are seen in Hartnupp's disease. Now, your vitamin B3 is synthesized from an amino acid which is your tryptophan. Now, what happens is in your Hartnupp's disease is that tryptophan absorption decreases. Okay, so if the absorption of tryptophan decreases, this tryptophan will not be able to synthesize niacin. So this is one way where niacin will be deficient. Okay, so this is also going to lead to pellagra like symptoms. And what is the condition? Hartnupp's disease. Okay. Apart from this, there is a tumor, carcinoid tumor of Argentophin cells. So what happens that these cells are hungry, and they are going to use all the niacin. And what happens is, the serotonin will be produced by the tumor of the cells and the whole pathway. So because tryptophan is going to synthesize B3, and it can also synthesize serotonin, which we will read in amino acid metabolism. Now, if it is going to shunt towards serotonin synthesis, then B3 pathway will not be able to take place. So there will be decrease of niacin, which is seen in carcinoid syndrome. So first we read about Hartnupp's, second we just dealt with carcinoid syndrome, and third is your maize and corn diet. Now what happens is, then in maize and corn, there is a bound form of niacin, which is called as niacin, which you don't have to remember the form, but this also is a poor source of tryptophan, thereby leading to deficiency of your vitamin B3. Then your jawar and sorghum diet, which is, there in leucine, which blocks your QPRTase enzyme. So this you also read in PSM. So I hope you all are well enough in this. And then we have to water soluble vitamins. I just said to you that the deficient sorry toxicity of water soluble vitamins is not seen much, but this vitamin B3 is one of those which has toxicity, and this has been asked in a previous NEET PG question. So sometimes they also ask in FMG the previously asked NEET PG question. So please take a note of it, that prostaglandin mediated flushing is seen. Okay, they can give a picture or they can just tell you the history of flushing. How you can treat it? By giving aspirin or by giving a laropiprant drug, which is a prostaglandin antagonist. Okay. Apart from this, first is your prostaglandin mediated flushing, which is seen in toxicity. Second, glucose intolerance. You can see cystoid macular edema can be seen. It can also lead to gastric irritation and fulminant hepatitis and hyperuricemia. So these are all the toxicity. Uh, Yes, Virender, it will be enough for your FMG exam. Fulminant hepatitis and hyperuricemia. They don't focus on the reactions, they focus on clinical questions. Then we move to vitamin B5. Okay, B5 is present in your coenzyme A. All the coenzyme A, wherever you see, it requires your vitamin B5. They don't ask many questions related to B5. Okay, and also acyl carrier protein, which is there in your fatty acid synthesis complex. You don't have to remember the enzymes of fatty acid synthesis complex as well, because it has not been asked in the exams. The deficiency disorder of vitamin B5 is, okay, 5 you remember with B5. Okay, 5 remember with burning foot syndrome. So related to F, everything is related to F. Then we have vitamin B6, your pyridoxine, and the active form will be Balraj Kaushal. I just answered that it will be enough. Okay. And you just have to be with me, expedition doctor, and we will finish it on time. Pyridoxal phosphate will be the active form. We cannot take vitamins lightly, because this is a place where 2 to 3 questions are always asked. So you can't compromise on this topic. Coenzyme role of vitamin B6, the transamination reaction. So this is very important. I would like to highlight it so that you can revise it again. Decarboxylation reaction, transsulfuration reaction, and tryptophan metabolism. In all these places, vitamin B6 plays a role of coenzyme. And this has been asked glycogen phosphorylase enzyme. This vitamin B6 also plays a role there in glycogenolysis. So glycogen phosphorylase is the rate limiting enzyme of glycogenolysis. So that is also where it is important. Then we have pyridoxine dependent seizures. Now if it goes deficient, now I told you that there are reactions which occur because of vitamin B6, the transamination decarboxylation reactions, transsulfuration reactions, etc. So if it goes deficient, your serotonin will not be produced, okay, your neurotransmitters will be not synthesized, catecholamines will not be synthesized adequately, and this will lead to pyridoxine dependent seizures. So, if a neonate who comes with seizures and you are unable to treat that with anti epileptic drugs, then think of vitamin B6 deficiency. So, you can remember it with six. Okay, six, the seizures and the sideroblastic anemia, the ring sideroblast cells, which can be seen, and they can also give you the histopathology image as well. And pellagra like symptoms will also be seen because of the enzyme kinurenase is decreased and the niacin will not be synthesized. Then we have your vitamin B7, the biotin. Okay, it is important for the carboxylation reactions, and the enzymes are written all here. Your pyruvate carboxylase, acetyl coenzyme A carboxylase, and propionyl coenzyme A carboxylase. So these are the ABCs, okay, because they required your carbon dioxide. B is for vitamin B7, okay. And then, very important, that if they give you a history that some person is eating raw egg, so raw egg consumption is going to lead to deficiency of vitamin B7, because raw egg has certain chemical which is called as avidin. This inhibits biotin, which leads to the deficiency of vitamin B7. What will be the symptoms of vitamin B7 deficiency? Hallucination, scaling, depression, seborrheic dermatitis, and erythematous rash. Okay, so then we don't have to remember the test, so you can skip about the test because they're not asked in FMG. This sensory neuropathy, again I told you that only two water soluble vitamins, your vitamin B5 and this your B6, causes toxicity, and this is going to cause sensory neuropathy. Now we move to the minerals. Your copper deficiency, Wilson disease is, I think, everyone's favorite, right? You must be aware of Wilson's disease. The mutation in ATP7B gene, this does defective copper transport. So, if the copper transportation is defected, it accumulates in various tissues and liver, which is going to cause the major issues. And accumulation of this in the eyes can be seen as KF rings, as you can see in the image given. Then we have Menkes disease or Kinky or Steely hair syndrome. Here we have ATP7A mutation, which is going to uh, be a defect in copper transporter in intestine, particularly. Okay. So now we move to selenium, zinc, and again we have to read about selenium. The most important is the antioxidation function and all the enzymes which your glutathione peroxidase, very favorite these days. People take glutathione injections as well. Why? Because it has antioxidation property, and this glutathione peroxidase also maintains your RBC's membrane integrity. So if this goes deficient, your hemolysis can happen. Okay, so that is why your selenium is important, because this is going to be the part of enzymes like glutathione peroxidase. Then the deficiency of selenium is going to cause Keshan disease, and you can write it backwards. And this is endemic to China itself only, and cardiomyopathy is the deficiency disorder. Okay, then another is Kashin back. Okay, so back is going to remind you of joint disorder. Okay, and this also happens because of the loss of iodine, less of iodine levels. Then apart from this, your for zinc, the most important is ectodermatitis enteropathica, which we'll be studying in detail in enzymes. And this has been asked, a baby's image with perioral and perineal rashes. Okay, that will be given in question if they want to ask you this. Apart from this, the deficiency of zinc is going to cause hypogeusia symptoms, so the patient will not be able to have proper of taste sensation. Okay, then chromium, they won't ask it, but it also potentiates the action of insulin and impaired glucose tolerance. So just give it a reading and we can focus more on the important things. Now let us discuss about a few questions which has been asked. Shehnawaz, you can ask from your fellow mates. They might share on the group, or you can see on the Telegram group. Now, answer this question. 34-year-old male. Staple diet primarily consisted of only maize. So, maize is going to remind you of what? Okay, then the D's, the diarrhea, dementia, the photosensitive dermatitis. Definitely, it is your niacin. Okay, so vitamin B3 is the answer. Everyone answered correctly only. Then we discuss the next question, the maturation of collagen. I told you yes, P1307, absolutely. The next question is B. The answer for this is ascorbic acid. We also will study it in proteins. Next, we move to a male patient presented with complaints of imbalance, numbness of the foot, and muscle weakness. So now you can see, and on history taking, he revealed that he has been taking multivitamin tablets more than the prescribed dose. Now, this kind of history is pointing towards toxicity. So, this thing should make you understand that toxicity can happen in only which two places. C, you no, Saurabh. The answer for this third question is not C. I told you toxicity for only two vitamins. Anyone? What is the answer? Two water soluble. Okay, yes, someone has answered correctly. The answer to this question is vitamin B6. So we just discussed this. I will show you sensory neuropathy. Okay, so this question is actually has been asked. So you have to just focus about two conditions which are related to toxicity and water soluble, and that will be enough for you. No one has to worry about if this much amount of information is enough for exam, because that is for sure that it is enough. Then which of the following is least likely to cause beriberi? Beriberi, one thing you should come into your mind is B1 deficiency, right? So now B1 is chronic alcohol intake. They definitely have a B1 deficiency. That's what we discussed. Anyone who can tell the answer? Bariatric surgery. Yes, someone is answering already. Dr. Expedition, the vegan diet, right? Because this definitely has your vitamin B1. So we don't have to worry if the person is vegetarian, he will not have any B1 deficiency. Next, we move quickly to the one of the other important topics of the exam, your enzymes. So I don't want to waste time on definition. We all know that enzymes are proteins except for ribozymes, which is your peptidyl transferase, okay, 20SR RNA, which helps in translation, and snRNA and group 2 introns, which help in RNA splicing, and your ribonuclease P, which helps in post-translational modification of transfer RNA. So now we will just move to the types of enzymes. We have simple enzymes and complex enzyme. So wherever it will be important for you from exam point of view, I will focus on that part. Simple enzyme is only having the protein part in it. Okay, so it is called as apo enzyme, and the complex enzyme has two parts. The apo enzyme part, that means the protein part, and the non protein part. So that is why protein plus non-protein part of the enzyme, we call it as holo enzyme, the complete enzyme. So the protein part is the apoenzyme part, and the non-protein can be a cofactor and the coenzymes. Coenzyme, which we discuss, most of your B complex enzymes are the coenzymes for your known protein part of the enzymes. So your vitamin B1, thiamine, is one. Okay, where the active form of it is thiamine dipyrophosphate. And we have already discussed the oxidative decarboxylation reaction and transketolase. So they can also give you history related to vitamin B when combining with the enzymatic activity. Then we have riboflavin, the active form being the FAD-FMN. So we have discussed, that is why I'm taking it quickly. The succinyl and the acyl coenzyme A2 dehydrogenases are there, which are important for the vitamin B2. On the other hand, rest of the dehydrogenases, whichsoever is left, we use NAD and NADP, the active form of niacin vitamin, for other dehydrogenases. Then we have, I told you, wherever you see coenzyme A, there you focus on pantothenic acid, your vitamin B5, and pyridoxine is for your pyridoxal phosphate. So this is important, your amino acid metabolism. Okay, the transamination of your amino acid, transsulfuration reaction and decarboxylation reaction. And remember the pyridoxine dependent seizures as well in neonates. Apart from this, your heme synthesis enzyme and glycogen phosphorylase, which has been asked previously. Folic acid tetrahydrofolate, folate or folic acid, all one carbon reactions, which we have already discussed in vitamins. Then we have cobalamin. The two active form of cobalamin are methyl B12 and adenosyl B12. Then the enzymes which are important are methionine synthase, methyl malonyl coenzyme A mutase. For ascorbic acid, very, very important, has been asked, your hydroxylation step of collagen synthesis. The prolyl hydroxylase and lysyl hydroxylase are the two enzymes which are important, and this has been asked. So I will ask you to focus on this more. Okay. Then let's discuss about the cofactors, the inorganic part. Okay, the zinc, the reaction catalyzed by zinc is carbonic anhydrase. Focus more on alcohol dehydrogenase and cytosolic SOD. Okay, I told you that we will be discussing about zinc deficiency in enzyme. So this is here. It was asked in FMG Jan 2025, the last year itself. So the patients with zinc deficiency, the babies will have diarrhea, okay, and the perioral and acral rash. So the mere treatment for this is just supplement the baby with the zinc, and alopecia will be there, and diarrhea will also be there. Then we have magnesium. Magnesium is involved in various reaction wherever ATP is needed, the kinase, phosphatase, mutase, and enolase. Then we have iron. Iron, we know that there are two forms of iron. We also studied in pathology, heme iron and the non-heme iron. Heme iron is important for your complex 3 and 4 of ETC. Okay, and complex 1 and 2 of ETC requires the non-heme iron. Then we have manganese, which is important for your kinase and phosphatase enzyme, okay, and mitochondrial superoxide dismutase. Then we have your molybdenum, which is important for xanthine oxidase, okay, and potassium for sodium potassium ATPase. Then you have copper. Copper again is important for your tyrosinase. Why? Because it is going to lead to melanin production. So wherever you see copper deficiency, the tyrosinase enzyme will not be able to function. So the loss of pigment, the melanin will be there. So focus on this more. Okay, so I'm highlighting some important points for you because you have to focus them on them more, and you have to reread them a day or 2 days before exam. Okay, so as we said that because tyrosinase enzyme will not be able to function if there is a copper deficiency, so there will be depigmentation. Okay, and again, because the collagen is affected, the picture will be a little bit similar to scurvy. So you should be able to differential diagnosis should be, you should be able to differentiate it. So I guess we did not read about vitamin C in vitamins, and that is important. So I just happened to skip that. Now ascorbic acid was left, so I would like you to take back to that. The functions of ascorbic acid are important, as we discussed a couple of times by now, that collagen synthesis is one of the function where it is involved in the hydroxylation reactions. Okay, and iron absorption is another thing which is important because of vitamin C. And the enzyme ferry reductase requires vitamin C. Tyrosine metabolism is also the important area, and the bile acid synthesis. Okay, so the deficiency manifestations again are important. Bleeding manifestations will be there because the collagen synthesis is getting affected. Okay, and iron deficiency anemia because it is important. Vitamin C is important for the absorption of iron. So you can see there will be splinter hemorrhage because of the bleeding manifestation, and there will be heme arthrosis, and there will be scorbutic rosary. So there was another place where we read about this these kind of manifestation, but these scorbutic rosary are tender and angulated. But the place where we read the rachitic rosary in vitamin D deficiency, they were not tender. So if you touch, the patient will be wincing. Then the Barlow's disease. So the breastfeeding infant, that will remind you. Okay, B for Barlow, breastfeeding infant. Well, this baby will stop breastfeeding. The age of weaning, the weaning age, the 6 to 12 month age, that will also because the vitamin C they are not taking in diet, and the mother's milk they are weaning off. So that is why infantile scurvy is there in Barlow's disease. And what treatment you can give? Just supplement the baby with vitamin C. Next, we move back to enzymes. Yes, Dr. Expedition, you're absolutely right. The class of enzyme, I will quickly take you through the classes of enzyme, the classification, because particularly the direct questions are not asked much. The oxidoreductases are having dehydrogenase, oxygenase, and oxidase and peroxidase as subclasses. So first class is oxidoreductase. So they will be involved in oxidation reduction reactions. The dehydrogenase will be involved in removal of hydrogen. So this directly will not help you, but it is going to help you in understanding your metabolism and metabolic pathways. So NAD or FAD, we have already discussed their examples. Okay, and monooxygenase. If the substrate gets added with only one atom of oxygen, then it is a monooxygenase. If we add two atoms of oxygenase, then it is dioxygenase. So dioxygenase enzyme very important in homogentisate oxidase. So the deficiency of homogentisate oxidase leads to a very important disease. I expect this answer to be coming in the comment box. Okay, so I will wait and will move ahead. Complex 4 of the ETC has oxidase enzyme, and peroxidase, very important, glutathione peroxidase, which we have already discussed. Okay, so this is going to we will discuss it later on in another topic. Catalase enzyme, just you have to remember about this that it is the marker enzyme of the peroxisomes. Anyone who can tell me the homogentisate oxidase deficiency is going to lead to which disorder? I'm still waiting for your answers. Then we move to the second class of enzyme, transferase. So the name itself is telling that it is going to transfer the functional groups. So we have kinases and phosphorylases like hexokinase and glucokinase, and glycogen phosphorylase is the enzyme. Yes, Dr. Expedition, absolutely right. Then we have the third class, hydrolase. These enzymes, the name water hydro is going to suggest they add water and break the covalent bonds. So all of our digestive enzymes are hydrolases in nature. Then we have arginase and the phosphatase apart from this. Then we have lyase. They break the covalent bond, but without the involvement of water in them. Okay, we have aldolase, fumarase, aconitase, etc. in them. Then we have isomerase enzyme, which produce the isomers, like isomerase itself will be the name in the questions. Sorry, in the enzyme's name. We have mutase and racemase. Then we have ligase. Ligase, the word ligase means joining. So, like synthetase enzymes, carboxylase are the examples of it. And last, we have translocase, which are going to help in the transfer of ions and molecules. Then this was asked that enzyme the mechanism of action of enzyme. Now a reaction is going to happen. This reactant, let's say, is going to convert it into the product. But why we need enzymes? So enzymes functions by lowering the activation of energy. That is important for you. So if you can see the above line, which I have highlighted with the blue, is without any enzyme. So the reactant got converted into product, but the activation energy was very high. But when the enzyme came, with the enzyme, they lowered the activation energy, so it got easier for the reaction to happen. Otherwise, the delta G is not changed. Okay, the delta G still remains same. No change in delta G. You have to focus. They can ask, but just enzyme actually lowers the activation energy, the enthalpy or the free energy of reactant or product still remains the same as the reaction progresses. Then there are the theories which were given, the Emil Fisher's template theory. When this scientist compared enzymes active side like a lock and key mechanism. So we know that a particular lock can be opened by a particular key because the keyhole in it is compared to the active side. So that is how when the substrate come and binds to the active side of the enzyme, that is the time when the reaction is going to happen, because the other molecules cannot come and attach to the active side. But this theory failed to tell about the transitional state changes. Okay, so there happens the changes in the transitional state which were not able to be explained by this theory. That is why we came up with another theory, the Koshland's induced fit theory. Okay, so the conformational changes in the active site induced by the substrate. So imagine if we wear gloves. Okay, so it is also called as induced fit theory, because if same gloves are worn by two different people, after wearing they take the shape of that particular person's hand. So similarly, when the substrate comes and binds to the active site of enzyme, there happen some conformational changes in the active site of enzymes which make it fit exactly into the enzyme. So this can be seen in the diagram, and the product is formed in the end of the reaction. Okay, then this is important. The enzyme kinetics is important. I hope all of you are listening to the class. So this has been asked previously as well. Dr. Expedition, let us discuss about substrate concentration first. Okay, if this is the substrate concentration on the x-axis, okay, and this is the velocity of the reaction. If we take y-axis as to be the velocity of the reaction and we make a graph, this comes to be a hyperbola. Okay, and this is called as Michaelis-Menten equation. What does it say is that a reaction, when it proceeds, as the substrate concentration increases, there comes a certain point at which the velocity will not further increase because all the active site will be used up. So this place is the place where the uh, reaction attains its maximum velocity. Okay, so if this is a Vmax and we happen to take half of Vmax, okay, Vmax by 2, and we plot a graph and we take it on x-axis, the substrate concentration at half of Vmax is your Km, your Michaelis Menten constant. Okay, so the Km is represented like this. Now, why we are studying this? Because the Km of any enzyme, of any substance, represents something. If Km is higher, the affinity will be lower. So Km is inversely proportional to the affinity. So all of you have to remember this. So if affinity is higher, then Km has to be low. So another thing, if I want to find the ideal substrate for any reaction, should it have a higher Km or lower Km? Can anyone tell? So ideally for a reaction to happen, the substrate should have higher affinity, right? So for higher affinity, the Km should be, yes, Kirti, Kiru, can you tell the answer? Just put some logic into it. If Km is high, affinity will be low, and if Km is low, the affinity will be high. So for an ideal substrate, it should be, the Km should be low because we want the reaction to happen nicely. So ideal substrate should have a low Km. So if they give you multiple options, you should be able to pick that on the basis of this. Okay, then to make the equation simplified, we plotted this graph. So this was a hyperbola curve, which was represented by V is equals to V mass into substrate concentration divided by Km plus substrate concentration. So this gives a hyperbola curve, but that makes our calculations very difficult. So we just plotted one thing, which is 1 by V, and we just reciprocated this whole reaction, which gives us the line Weaver Burke plot, which is this. So please tell me that the x intercept represents what and y intercepts represent what here. Yes, competitive and uncompetitive we will move, but before that you have to distinguish between the y and x intercept. Quickly, I will also tell you enzyme concentration. If this is the velocity and this is the concentration of enzyme, then enzyme concentration is directly proportional to the velocity. So if we have more enzyme, the velocity of the reaction will be more. Then the temperature and pH. If, again, this is the velocity of the reaction. And if we increase the temperature, so this comes out to be a bell shaped curve because we know that enzymes are proteins, and the proteins they denaturate at very high pH, at very high temperature. So this comes out to be a bell shaped curve, and this is the optimum activity place. Why? Because we know that our human body also works at a certain temperature. So if someone gets febrile, okay, so the enzyme starts to get denaturated. Then we move to, as everyone, as a few students were commenting in the exam, X is Km and Y is Vmax. Absolutely right. So if we talk about enzyme inhibition, okay, the competitive inhibition of enzyme, the non-competitive and uncompetitive. Okay, so the graphs have been asked previously, so you have to focus on this. When in case of competitive inhibition, the inhibitor is a structural analog of your active site. Okay, so if let's say this is your inhibitor and this is your substrate, okay, so they are exactly the similar, so they can go and compete for the active site. That is why this is called as active inhibition. So for competition we have to run extra miles, extra kilometers. So you can see the graph. Okay, so V remains same, V max remains same. You can see the green and red two curves. So one is with the inhibitor and one is without the inhibitor, but the Km you can see has been increased. So this is the feature of competitive inhibition and the Lineweaver-Burke plot. So, to run for extra kilometers, you have to cross everything. When there is a lot of competition, you have to cut down to your, Instagram, your all every extra unnecessary things. So the graph will come to be X. Okay, you can see, just see X and mark the answer for as competitive inhibition. The examples of this are most of the drugs like methotrexate, statins, dicumarol, and ethanol, and malonate is one of the poison. Okay, and the enzymes related to this are also written, but you focus on the graphs. My main idea is to make you learn about the graphs. Okay, remember the X thing, X shaped graph. Here we can see is the Y. Okay, and this is the non-competitive inhibition. Now what happens is non-competition, the active site, the enzyme is coming, sorry, substrate is coming to the enzyme's active site, but the inhibitor in this case is not a structural analog to the substrate. Okay, so that is why there is a not a competition for the active site. What happens is, for inhibitor in this case, there is another different binding site which is there, and this kind of so here, how you will distinguish it, the graph, in the other graph we saw that kilometers in competition we have to run extra kilometers. Here the km will be same. Okay, you can see that, and you can see there is a change in v max. Okay, that is how you can differentiate it from the competitive inhibition. And the graph here is going to be y shaped. Okay, so you have to just learn and pick the words right now. So examples of it, you should be able to know cyanide is important. Okay, carbon monoxide is important. You at least try to remember these two. In case of non competitive, they sometimes can ask you, just they can give you graph and they can ask you that what kind of graph is shown by which one of the following inhibitors. Then we have uncompetitive inhibition. Here you will see a parallel line graph which can be seen. So inhibitor, they binds to the enzyme substrate complex. So the substrate comes and binds to the active site of the enzyme, and the inhibitor also comes and bind to the same thing. The phenylalanine is going to inhibit the placental alkaline phosphatase. This is one of the examples for this kind of competition. Then suicide inhibition, you just remember allopurinol, very important. It inhibits your enzyme xanthine oxidase and used in the treatment of which disease? Anyone who can tell? Dr. Expedition. You also can remember aspirin, the cyclooxygenase inhibitor. Yes. So let us move quickly to the clinical enzymology then. Yes, Dr. Expedition, it's in gout. Lactate dehydrogenase was asked in LDH1. Okay, so we have one heart. We do have a one heart. That is why the LDH1 isoenzyme of lactate dehydrogenase, which has 4 units of H. Okay, so how do you remember? Heart has also 4 chambers. So this is an isoenzyme LDH1, which is localized in heart. So we can also use it in diagnosis of MI. And then we have LDH2 and 3. Okay. So 3 is located in brains. There is certain discrepancy. Probably it has been incorrectly shown here. So it is present in brain, and LDH4 and 5 are for liver and skeletal muscles. Okay, this you have to remember. LDH2 is for 2. You remember 2 with your RBC. And again, for 3, you can make a B out of 3. So 3 is located in your brain. Then you move to creatine kinase. Creatine kinase 1 is located in brain. Okay, and 2 is located in heart. So this is how you can remember. This clinical significance is MI for CK2, and for brain it is cerebrovascular accidents, any infarcts which can happen. So these all enzymes are used in investigations of the diseases, so they'll be elevated in respective disorders. Then your CK3, so 3 you can just do it like that, flip it. The muscle injuries and myopathies, that is this clinical significance, because it is present in muscles. Okay, so the subunits are also related to MM. Then the ratio in MI, the LDH ratio, it is getting flipped. This has been also asked, so you remember this. Okay, normally LDH2 is more than LDH1, but in MI, so MI is a heart condition. So in heart, we again have one heart. So what is raised? LDH is raised more. So we can see a flipped pattern of LDH. Okay. So that is another thing. Then we have alkaline phosphatase. The isoenzymes, they have not asked much about alkaline phosphatase, but at least you can have some basic idea of this. At least try to remember the clinical significance of all these. And ALP1, alpha 1 ALP is going to be present in the epithelium of biliary canaliculi. So that this is the reason it marks the cholestasis condition. Then next we have the alpha 2 ALP, which is heat labile form. The location is present. It is present in the hepatic sinusoidal cells, so it marks the hepatic injuries. Then we have alpha 2 ALP, which is present in the placenta. Okay, so placenta is formed when the female is pregnant. So you see the one person is becoming two. So the ALP2, and it is the most stable form. You just have to, there is no such clinical significance because it is a physiological rise which happens in pregnancy. Okay, so if you see a pregnant female and raise in ALP, you don't consider it as pathology. It is a normal condition. Also, because this is the pre-beta ALP, which is the form present in the osteoblastic cells. Now, osteoblastic cells are going to help in the growth of the bone. So, any person who's having a puberty age obviously is going to have a lot of osteoblastic activity. So that again is going to have a physiological increase in ALP. But apart from this, there are two disease conditions where Paget's disease and vitamin D deficiency. Now, a lot of breakdown is going to happen, which is going to release in pre-beta ALP, thereby leading to raise in ALP. And this happens in Paget's and vitamin D deficiency. Then we have another form, your gamma ALP in the intestinal cells. So it is found to be raised in ulcerative colitis patients, and the leukocyte, particularly the name itself is telling you the leukocyte. So it is raised in leukemias. Okay, so next we have regulation of enzyme activity. So just I want you to remember about the covalent modification because this has been asked previously in exam, in your FMG exam itself. And I hope you know about this. All of you are with me in the doctor expedition who was actively participating as well. Zymosin activation, your all those zymogens which are the inactive form like trypsinogen getting converted to trypsin. So this happens because of the covalent modification of the enzymes, and all your clotting factors, they also gets activated about after the covalent modification. Then your very important phosphorylation, dephosphorylation, and this is a reversible thing because you see all the enzymes. Your insulin, the hormone of which state, fasting or fed state hormone. So whenever insulin comes, insulin is going to be there. And remember, it is like ID card. So insulin actually dephosphorylates. So all the enzymes which are going to, all the metabolic pathways which are going to work in fed state, they are actually be active in dephosphorylated state. So this is going to help you solve the MCQs. Okay, that is why I've given you this mnemonic. Whenever any enzyme, they ask you which state it is going to happen, in cases of sometimes they give you any particular reaction. Let's say glycogen synthesis. So glycogen synthesis is going to happen in fed state, right? So you have to remember like that. If it is fed state, then what is the hormone? Hormone is insulin, and it is going to do the activation of enzymes in fed state. Sorry, dephosphorylated state. So which is the rate limiting enzyme? glycogen synthase. Okay, so this is going to come and put a phosphate group on the glycogen synthase, and glycogen synthase will be activated. So this is how enzyme activity is regulated by covalent modification. There are some allosteric modifications are also there, but they haven't asked, so I have not included. They'll probably not even ask you this. Then let us discuss the questions itself. Which of the following best describes the control of enzyme activity by phosphorylation or dephosphorylation? Just now I told you. Covalent modification, absolutely. Then we have the inhibition, which is shown in the image. I told you that just look at the Kirti Kiru, the non-competitive, yes. You remember the competitive will have X, the uncompetitive will have a parallel lines, and the non-competitive you will see a Y kind of a structure. So just quick questions are asked in these. So you just don't have to go into the lot of depth. Then carbohydrates. Let us start with carbohydrates. Are you all with me? Can we begin with carbohydrates now? We will not go into a lot of chemistry part of carbohydrates or lipids or a little bit of amino acids we will discuss, but because they are asked. But I have taken only the important parts of carbohydrate because this is a rapid revision session. So the glycose aminoglycans, okay, the mucopolysaccharides, they are very important and they have been asked. So they are heteropolysaccharides, which are made from repeating disaccharide units, different. So chondroitin sulfate is the one which is present in bones and cartilage. So chondro word itself is going to tell you about the cartilage. Okay, so remember chondro present in bones and cartilage. Then we have keratin sulfate. So kerato word reminds you of cornea, right? So this is made by N-acetyl glucosamine galactose. Okay, and this is the glycosaminoglycan, which do not have any uronic acid. So for at least two or three of them, I have also written the constituents. You just have to remember for all these three and not related to the rest of all. Then this keratin sulfate is of two types, KS1 and KS2. So the one is present in the cornea and it helps in the maintenance of corneal transparency. So the word kerato should make you understand this thing. Keratin, cornea. Okay, so that is enough for you. Then let us discuss about dermatin sulfate. Okay, the derma word itself is going to tell you it is present in your dermis of the skin and in the sclera is also. So D is going to remind you of do in Hindi, you say, okay, do. And then sclera is also the S second and it is also atherogenic. So these three things. Just pick the main points for rapid revision, that will be enough. Then you have heparin sulfate. Okay, the heparin sulfate, it gives the charge selectiveness of the glomerular basement membrane. So you know that there is a negative charge which is present. So that is why this heparin sulfate is going to give a lot of negative charge, and that is the reason for charge selectiveness of glomerular basement membrane. It also is there on the plasma membrane receptors and lipoprotein lipase. So just remember heparin sulfate and already the enzymes. Okay. Then we have rebel, but you have to qualify your exam this time. So just focus on studying right now. Heparin is formed by glucosamine and iduronate acid. This is for present in the it is the only intracellular glycosaminoglycan. So you know that it is present as anticoagulant even in your if you have done clinical practices in your colleges, you must have be aware of heparin already. It is also used in estimation of lipoprotein lipase. Okay, so I will ask you to focus more on chondroitin sulfate, keratin sulfate, and then a little bit on dermatin sulfate. Then your hyaluronic acid, this gives the shock absorbance to all your the joints, and it also helps in wound healing, tumor metastasis. Okay, so that much is important. Don't go in depth of others, just focus more in chondroitin and keratin sulfate. Then the disorders related to this is very very important, so please focus more here on this area. Whenever the mucopolysaccharides, the degradation, so degradation is necessary, but if the degradation is affected, okay, because impaired degradation of mucopolysaccharides is going to cause mucopolysaccharidosis, and degradation occurs in lysosomes. So if it is affected, the disorder which is called as lysosomal storage disorder. So in general, what is going to happen, as we have already discussed about the cornea, right? So corneal opacity, frontal bossing, as you can see here in the image, and just a minute, depressed nasal bridge. These are the generalized conditions which are related to all mucopolysaccharidosis. So you just this will be given for all the conditions. That is why I have just taken it on the above of the table. And what you have to focus more specifically on, if we discuss Hurler's disease, what is the differential diagnosis, how you can make it, that is going to impact your revision. Okay, so they have a protruding tongue as well, macroglossia. Okay, because of macroglossia and clawing of hands, you can see they can also have umbilical hernia. So these are conditions which are present in all mucopolysaccharidosis. Then, as Rebel is saying, Hurler Hunter, right? Hurler's disease, the enzyme defective is L. Hurler enzyme defective is L. Iduronidase. Okay. So what is going to happen, because corneal opacity is there in everyone. Okay. So this is going to cause the visual disturbances. MR is for mental retardation, and umbilical hernia we have already discussed, and there will be short stature in them. Then we have Shee's disease, the type MPS 1. Okay, what is going to be there? There is a partial defect in the same enzyme which is there in the Hurler's disease, and these people have normal intelligence. So remember it like that. The she's are intelligent. Okay, so they have more intelligence. That's just a mnemonic. Don't take it otherwise. And these patients will also have hirsutism, coarse facial features. So think, if the intelligence is given normal, there is no mental retardation, you can think of Shee's disease, and the enzyme defect is same. Then we have a Hunter's disease, which is MPS 2, the X-linked recessive disease. Now, for hunters need a very clear vision for hunting. That is why they have clear vision. So all these points which are given in highlighted, different colors, you have to focus more on them. The enzyme which is deficient in them, yes, expedition, we they need vision. Iduronate, sulfatase. Now, sulfatase, S is going to remind you of 2. Okay, so this is MPS 2, Hunter. So T is also going to remind you of 2. So the Hunter disease, iduronate, sulfatase, and the clear vision is also going to make you the diagnosis. Then we have glucose transporters. This is all about the mucopolysaccharidosis. These questions are like this, that you have to revise enzymes a day before exam. So there are certain topics in pharmacology, microbiology, and biochemistry as well that you have to focus a day before exam, because enzymes and vitamins you probably don't need to revise, but at least these enzyme defects, because they can be confusing. So please revise it a day before exam. Are you all good? Able to understand? I hope that we are not moving too fast. Yes, I do use sulfatase. Rebel, you're right. Then we move to the glucose transporters. We have two types of glucose transporters. One is the sodium sodium dependent, and the other is glutes. Okay, so SGLT is sodium glucose linked transporter. Okay, these are dependent on sodium, so everything is for with an S. Sodium dependent, why they are sodium dependent, they are going to transport glucose along with sodium, so there is a symport which is happening. Both sodium and glucose are going to be uh, transported along with each other. Then they have secondary active transport. This has been asked, so you have to remember this. And they have single or unidirectional in nature. They are going to transport in single direction, and they work in against concentration gradient. That is why they are active transport. Okay, so the basically the application of this is giving ORS. You know that whenever the patient is having dehydration due to diarrhea and all, we give ORS because it has both sodium and glucose. So this is going to improve the symport, and we can save the sodium and glucose. Then we have the glutes, which is very, very important. This is the sodium independent one, bidirectional in nature. So whatever is not there for SGLT is there for glute. Okay, and they follow a ping pong mechanism, and they are passive in nature. They have facilitated. Please focus. They can sometimes ask, although these kind of questions are old pattern questions, but they still can ask sometimes. So this is about glute, all the glutes, and focus on all the important points which I tell you. The glute one, okay, so one is present in brain. So you write it like this, brain. Okay, so this is present in brain. We have one brain. So GLUT1 is present in brain. And then also neurons will remind you of brain 3. So again, your previous old mnemonic of B, out of a B, you can make a 3. So GLUT 3 and 1. Think of this all together for brain. Okay, then placenta and kidney. So these are similar. That's why I study GLUT 1 and GLUT 3 together. Then you come on to RBCs, which is there only in GLUT 1. And at least this much is important. What is important is it is having low km. Low km, the good substrate. Remember the application which we read in enzymes. This is having high affinity for glucose. So even if there is a very less amount of glucose left in the body, RBCs or brains, they can still fetch up that glucose from the blood and use for their energy purposes. Because you know that brain requires glucose for its energy requirement, right? So that is the importance that it has low Km. Please focus on this low Km for GLUT1 and brain and RBCs, these points. Then we have GLUT2. We have this is present in the beta cells. This has high Km, important again. So it is active in fed state. So for synthesis of insulin, it has some role which you will be seeing later on in metabolism. Also present in sinusoidal. So 2 reminds you of B, beta, and S is also the second. So that is how you can remember all of these sites. Then the GLUT 3. GLUT 3 has lowest Km. Again, I told you that low Km is going to help them with, even if the glucose is very low, then also these cells can take up the glucose. Then we have GLUT 4, very important. It is insulin dependent GLUT 4. Okay, so GLUT 4 is insulin dependent. This point is very important. And where it is present in heart, skeletal muscles, and adipose tissue. Okay, so this is all about GLUT 1 to 4. Then 5, F for 5, F for fructose transporter. That you can remember. Now only little bit points about GLUT 6. Pseudogene, not very important though. 7 is for transport of glucose 6 phosphate to the smooth endoplasmic reticulum, which you can study in glycogen metabolism. Then we have GLUT 8, which is present in blastocysts, and GLUT 9 is involved in the uric acid transporter, and it is defected in primary gout. Okay, so now who can answer this question? We have not read the carbohydrate chemistry because most of the times they don't ask these questions, but this is one of the old pattern questions, so I have included it. So which of the two monosaccharides are constituents of lactulose? Yes, A, B, C, or D? Anyone who can answer? Rebel is saying D, fructose and mannose. Dr. Expedition. I hope you're all listening to the class. So someone has got up with the correct answer. The answer is galactose and fructose. Okay, so still I would ask you to focus more on the other parts, but because they don't ask these type of questions anymore. This was one question which was asked, so that's why I included it. Then we now move to the metabolism part. Now, before we start with the metabolism, are you all good? Does anyone want to take a break? Okay, we can have a very short break of 10 minutes, and then we can continue with the session. Let's take a 10 minutes break. See you after 10 minutes. I hope you're done with your small break. So we have to wrap up biochemistry quickly. Your exam is also coming up very soon. So let's continue with the metabolism, the place where we just left before the break. So before metabolism, as I told you that I would like you to tell a little bit about fed and fasting states, and let us start with the well-fed state. So once you have had food, let's say if you had your food in your break time, so 1 to 4 hours after your food, we call it as well-fed state. So what happens in well-fed state, that as soon as your glucose levels rises beyond more than 70 milligram per deciliter, your GLUT2 gets activated. Now we have already discussed about all the glucose transporters before the break. So this is present in the beta cells of pancreas. So this glucose will be taken inside the pancreas, and this glucose will be going into the glycolysis. What is glycolysis? The breakdown of glucose into pyruvate. Okay, so glucose gets converted into pyruvate in aerobic glycolysis, as I'm telling you, and this is going to generate ATPs. Now, once ATP is generated, this ATP to ADP ratio goes increased. Okay, so ultimately, what is going to happen? ATP sensitive potassium voltage gated channels are going to get closed, and this closure of potassium voltage gated channel, because they are ATP sensitive, is going to lead to depolarization, further leading to calcium influx. And this calcium which has come in is going to release insulin. It's going to push the insulin which was stored in the beta cells of pancreas. So now this insulin has come in the blood. Now this insulin glucagon ratio has increased, because as I told you that insulin is the hormone of fed state. Now this insulin, once it has come to the blood, all the glucose transporters, all the GLUT4s, they are going to get activated, and this glucose will be uptaken by all these GLUT4s as well, and the body will be utilizing the glucose which is coming up for different purposes. So, first, this glucose enters into glycolysis. Once the energy needs of the body are done, now the same excess of glucose is going to get converted to glycogen, which is the stored form of your glucose. Okay, so this is just forming, I'm trying to make up a basic concept for your metabolism ahead. And this stored glycogen, this can be used further in your fasting states. Apart from this, let's say there is an excess of glucose still after formation of glycogen, then the same is going to go in for fatty acid synthesis, and we will see it in later on in metabolism. And whenever the body will need, it will break down glycogen depending on which fasting state it is, or fatty acids, or your ketone bodies formation will start. So after fed state, you have to focus on fasting state. If let's say you're fasting and the early fasting state, so just after well fed state you are having early fasting state. So this early fasting, F is the sixth alphabet. Okay, is the sixth alphabet. So that is going to remind you of six. So four before well fed, you remember well fed is 1 to 4 hours. So from 4 to 16 we have your early fasting state. And now once you have started fasting, the first thing which is ahead of you is your stored form of glucose, which is your glycogen. So the liver, we have stored form of glucose, the glycogen in liver. So hepatic glycogenolysis is the main source of uh, energy during early fasting state. Why it is happening? Because glucagon is there predominantly, and all those glucagon, if insulin, I told you, is going to dephosphorylate the enzymes of metabolism, and glucagon is going to phosphorylate the enzyme. Okay, so the glycogen phosphorylase is the enzyme which is going to be phosphorylated, which is going to stimulate the process of glycogenolysis. Then we have a fasting state. Fasting state is of 16 to 48 hours. And what happens now? The glycogen which was stored in the liver is depleted. We don't have any more glycogen, so we move to gluconeogenesis. Anyone who can tell me the definition of gluconeogenesis? Gluco is glucose, right? And neo is, the all the new products. So ideally we synthesize glucose, we get glucose from the carbohydrate, but this glucose is produced from the known carbohydrate substances. So like amino acids, okay, we have glucogenic amino acids, okay. And this gluconeogenesis is a process which needs ATP, and from where these ATPs are coming, from fatty acid oxidation. So in lipid metabolism, we will read something called as beta oxidation of fatty acids. So this is going to generate ATP, and that ATP is going to come for gluconeogenesis. Then we have prolonged fasting or starvation. So this S is going to remind you of two. So actually, it's almost around 2 days to five. Okay, so S can be made like five. So 2 days to 5 days. This is the time period of fasting, okay, sorry, starvation. And then where prolonged starvation is more than 5 days. So if beyond 5 days you're doing fasting, then it is called as prolonged starvation. So, first of all, in prolonged fasting or starvation, what is going to happen? Now, you are done with your glycogen stores, you're done with your gluconeogenesis. What comes next is your fatty acids. So, the stored form of your fatty acids, the triacylglycerols in your adipose tissue, that is going to be hit upon now. What is the hormone? The hormone of fasting stage is glucagon. So this glucagon is important because it is going to activate your hormone sensitive lipase. So this lipase is going to break down the triacylglycerides into fatty acids, and this is going to produce acetyl coenzyme A, and this same acetyl CoA is going to produce your ketone bodies, which is the main source of energy in your starvation state, specifically for brain. Okay, and then your muscle proteolysis is something which is going to be there in prolonged starvation. So in the end, we gonna use the proteins. Initially, we don't want to use the proteins because they are the structural components. So only when prolonged starvation happens, we do the muscle proteolysis. Okay, so this question has been asked previously, so it's not very difficult to answer. Prolonged starvation, acetyl CoA is formed. So the answer is written in front of you only. What should be the answer? Saurabh Vyas's answer correctly, ketogenesis. So this acetyl CoA is going to help in the synthesis of ketone bodies, which is ketogenesis. Okay. Then this is a picture I have taken. This is basically integration of all the metabolic pathways. Okay, so actually you don't have to remember. Yes, this is ketogenesis. Integration of metabolic pathways. Actually, they don't ask you questions related to particular pathways. They don't. Don't have to remember all the reactions step by step. Mostly clinical applications are asked. Okay, so this is glycolysis. You just glycolysis happens, glucose is broken down into pyruvate, and it is a 10-step reaction. These are old kind of questions, nobody is asking these days. Okay, lactate is produced only in case of anaerobic glycolysis. Just focus on very few little things. When glucose is converted to glucose 6 phosphate, this same glucose 6 phosphate can go into glycogenolysis or glycogenesis. Okay, and this glucose 6 phosphate can also go into the HMP shunt. What is the major role of HMP shunt? It is to produce NADPH, and this NADPH is the having role in antioxidation and glutathione reductase. Okay, and then we have galactose metabolism, which can be seen but very less important. But you can see that this is glucose 6 phosphate has different fates. One going to HMP pathway, one going to directly first going to glycolysis. So when all the needs of glycolysis will be done, then only it is going to produce glycogenesis. Then this 14th is important for you, pyruvate. Okay, this acetyl CoA is going into TCA cycle. So this pyruvate, which is the last step or last product of your glycolysis, is going to get linked with the 14th number is your PDH, pyruvate dehydrogenase complex. This is also called as link reaction because it is going to link your glycolysis to your TCA. Okay, so just focus on only main things, and then this same acetyl CoA can go into your lipid metabolism in the synthesis of triacyl glycerides. Okay, and same from here, this acetyl CoA can also go in ketogenesis. So this is another intermediate which is important for different pathways. Okay, so I hope just don't focus on each and every reaction, just focus on rate limiting enzymes, and just have a little bit of idea and a little bit on pyruvate dehydrogenase complex. Now, a question related to where the pathway occurs has been asked. So I have just included this table that glycolysis, okay, out of a G, you can make a C. Okay, so this glycolysis happens in cytoplasm. Now, pyruvate dehydrogenase, this is a link reaction. For this, you need to move your reactants to the mitochondria. So this happens in mitochondria. Then we have TCA. This also happens in mitochondria. Then you have glycogen metabolism. Again, you can make a C out of a G, cytoplasm. Then we have a gluconeogenesis, which occurs in different organelles. So it happens in mitochondria, cytoplasm, and endoplasmic reticulum is also included. So mostly they don't ask such questions, but if they ask, you just have to have some basic idea. Okay, these are the two places, your urea cycle and heme synthesis, where both mitochondria and cytoplasm are required. And ketone body synthesis occurs in mitochondria, where in liver of mitochondria, we will also read them in respective metabolic pathways as well. Then fatty acid synthesis occurs in cytoplasm. So this is just a table which you have to kind of revise a day before exam, probably again. Then the applied aspects of glycolysis. So I have not included all the steps of glycolysis because it is not important for you. But there is this ninth enzyme, okay, which is your enolase, which is the ninth step of glycolysis. And we use it in estimation of blood glucose. How we use it? So there is a vacutainer, gray vacutainer, and this gray color vacutainer has sodium fluoride in it. So this sodium fluoride, this is inhibitor of enzyme enolase. So this inhibits glycolase, and that is why it can be used. Okay, so we can see that this question has been asked previously. So the answer to this, as everyone is already answering, sodium fluoride and potassium oxalate. Okay, this is all about it. And this arsenate inhibits the another enzyme of glycolysis, but more important is your fluoride. Then there is an application of glycolysis in your cancer cells, which is the Warburg hypothesis. I guess you also read it in pathology. You have already read. So this is oxygen O2. Even in the presence of ample amount of oxygen. So ideally what happens, we have aerobic glycolysis when there is enough of oxygen. And if our muscles do not, exercising muscles undergo anaerobic glycolysis because the oxygen is deficient. But in case of cancer cells, they are rapidly dividing cells. Even in the presence of enough of oxygen, what they take is a aerobic fermentation of aerobic glycolysis. Okay, so this is a different effect for them, and the Warburg is the scientist who discovered it. So just remember that cancer cells have something, related to Warburg hypothesis. You don't have to go into details. Then link reaction, your pyruvate dehydrogenase complex, which we have already discussed. This is the link to glycolysis, from glycolysis to TCA. So this links the pyruvate to the acetyl CoA formation. Okay, so the enzymes for this is these three: pyruvate dehydrogenase and dihydrolipoyl transacetylase. At least try to remember the first one. So how it is important clinically? One of the coenzyme is your vitamin B1 in these. So there is a group of 5 coenzymes, out of which B1 is one. And wherever there occurs deficiency of pyruvate dehydrogenase, the reactions are not being able to link. The glycolysis is not linked to TCA, which is going to lead to depletion of energy. Apart from this, the pyruvate can go to lactate formation, can go to acetyl CoA, but this is with the help of PDH, pyruvate dehydrogenase enzyme. This is not available, so all the pyruvate now is going to lactate formation. This is going to lead to lactic acidosis. So how clinically it is seen? So if an alcoholic patient is coming, you know that B1 enzyme is deficient in them. Okay, so if there is a B1 deficiency, your pyruvate dehydrogenase enzyme is not going to occur. This step of link reaction is not going to occur. And all the pyruvate which was accumulated is going to go and form lactic acidosis. So they will, if you do a blood gas analysis of them, you will have see acidosis in the patients of alcoholism. And the reason is this not working of PDH because of lack of B1. Okay, so that is how you can correlate it clinically, the chronic alcoholics. And polished rice, we have already revised it. Okay. Lactic acidosis doesn't mean less of oxygen. Lactic acidosis is because the lactate is produced. So here the reason is not lack of oxygen. Here the reason is this, that what happens, glucose going to form pyruvate. I'm explaining this for you, Saurabh, since you asked. Uh, Glucose converts to pyruvate, and this is glycolysis. Okay, so this is glycolysis. Again, you don't have to remember all the steps. And pyruvate goes to formation of lactate, and pyruvate has another fate. So this pyruvate has two fates, either formation of lactate in case of anaerobic glycolysis, ideally, or it can also go in PDH. So in normal people like you or me, your PDH link reaction will be working normally, and this PDH is going to link it with TCA, and lot of ATPs will be coming up from TCA. Again, you don't have to remember the whole energetics. Let's say 7 ATP are coming from your aerobic glycolysis. But now what is happening? This path is not occurring in patients. This PDH of which patients? Alcoholics, and wherever pyruvate dehydrogenase is deficient in those patients. And also in anyone who has B1 deficiency, like in alcoholics. Now, if this pathway is not being able to occur, your pyruvate gets accumulated. So this is the chemistry, law of chemistry. If A wants to convert it into B, and A is a lot more, then the reaction is going to go forward. So because of this, since the pyruvate is getting accumulated, the pathway is going to the formation of lactate, as it cannot go to pyruvate dehydrogenase side. Right? I hope you have understood now. So this is the reason for formation of lactic acidosis. Even though they have enough of oxygen, even you give them oxygen, the patients who are coming of with alcoholism, but they will have lactic acidosis. How do you rectify this? How do you treat them? You give them vitamin B1. Okay, you that's the treatment for them. Because why this PDH is not working? Because the alcoholics, they have decreased absorption of your vitamin B1, leading to defective pyruvate dehydrogenase. As I have told you, we have discussed in the beginning of class that PDH, they have one of the coenzymes is vitamin B1. Fine. Although there is a group of 5 coenzymes, but at least try to remember one, that is B1. So this is the explanation. These are the 5 coenzymes which I have been telling you. So B1, the thiamine pyrophosphate, coenzyme A, the B5, lipoamide, FAD, and NAD, B3 as well. Okay, but this is very commonly seen. Like even if I hope you qualify your FMG exam soon and you start with your internship, and you definitely are going to see this chronic alcoholic patient in your ward or emergency, probably not ward but emergency, because they land up into hypoglycemic coma. They come with acidosis, and you will be asked to take a blood gas analysis sample for them. So I hope that happens for you in this new year. So that is how, and you will be able to answer that uh, you should give them B1. So you'll be ready with the consultant level answer at that time. Then same coenzymes, all these five which are written above, are also there for other enzymes, your alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase. Okay, so I hope this is good enough. I hope you're understanding. Saurabh, I hope I was able to clear your doubt. Then we have chronic alcoholic patient question. This was asked. Reduced food intake over the past few months. Now, see, I told you that they are going to land up in hypoglycemic coma. Okay, so they have hypoglycemia. What is the most likely cause of hypoglycemia? Now you can tell me. Yes, this is the reason. Okay, so if you're good with biochemistry, you can treat all the patients because the basic lies here. Even the drugs are formed on this, the enzymes. Which one of the following enzyme is found to be deficient in von Gierke's disease? Anyone who can tell this, though we have not discussed? Rebel. Okay, everyone has come up with the right answer, the glucose 6 phosphatase. So that means this is the time to move to another very, very important topic, your glycogen storage disorders. Okay, so let's start with glycogen metabolism. We will not discuss because I just want you to remember that glycogen synthase is the rate limiting enzyme of glycogenesis, and glycogen phosphorylase and the enzyme rate limiting enzyme of glycogenolysis. That much is enough. And when does glycogenesis happen? It happens in fed state. And when does glycogenolysis happen? In early fasting state. If this much you know, which we have already discussed, that is enough for metabolism part. We are good. Then let's start with your glycogen storage disorder type 1A. So one itself name is telling you von Gierke's. Okay, so sounds similar. Von Gierke's disease. The enzyme glucose 6 phosphatase has been asked. So now if this is deficient, and we know that this is the important enzyme of your glycogenolysis. Now this is not happening. Now whenever you fast, whenever someone fasts, they will not be able to break the stored glycogen and produce glucose. In me or you, we can have even if we fast, we can break the glycogen and get the glucose. But in von Gierke's disease, they will not be able to break the glycogen. That is why hypoglycemia. And what kind of hypoglycemia? Fasting hypoglycemia. So you look for fasting hypoglycemia. So the mothers will be coming with the baby, let's say, and they will tell that the baby had not taken a meal in past 16 hours or 12 hours, and he is coming with hypoglycemia, and the baby is very probably can have convulsions and the coma on fasting, and they have massive hepatomegaly because the glycogen which is stored in the liver is not breaking down, and it is storing but not breaking down, so that leads to massive hepatomegaly. Okay, then we have type 1b glycogen storage disorder. Apart from this, they have neutropenia. And what is defective? Glucose 6 phosphate transporter is defected. Okay, so in type 1b, b you remind of 2. Okay, 2 is going to remind you of some transporter. So glucose 6 phosphate transporter, which is there in smooth endoplasmic reticulum, this is going to be defected. Then we have glycogen storage disorder type 3. So 3 is going to remember of you third alphabet, Cory's disease or Forbes disease. So there is a famous mnemonic of A, B, C, D. So you join your C with the D, A with B. Okay, so the Anderson disease have a branching enzyme defect, and your Cory's has a D branching enzyme defect. So all of us are aware of this mnemonic, as I can see. Then we have early morning hypoglycemia in them as well. but it is not fatal. Okay, so you can distinguish between this. Of course we can speed up, but this is an important topic, so you have to focus more here. Okay, so branching enzyme, don't forget about the enzyme defects. Fasting hypoglycemia will also be there in these kind of patients. Portal hypertension, and this is fatal, and this is going to lead to cirrhosis. That is important, and liver failure is the main reason for death. Then we have type 6. 6 is for Hirsch's disease. Okay. Then this, what is the enzyme? H for H. 6 is Hirsch's disease. Hepatic glycogen phosphorylase is the enzyme defect. Then we have muscle glycogen storage disorder. This has been asked. The Pompey's disease. Massive cardiomegaly is the uh, thing which can be seen. They can also give you an image. The infant will be floppy, there will be generalized hypotonia. And what is the enzyme defect? Acid alpha 1 for glucosidase or acid maltase. Okay, so this is fatal. The death within 2 years due to cardiac failure can be there. Then we have some glycogen storage disorder without any hypertrophic cardiomyopathy, the McCall's disease, which is going to be there, and the enzyme defect is muscle glycogen phosphorylase in them. So, what kind of clinical picture is going to come? Adolescent male will come, and he will be having pain in calf muscle. Okay, so because the enzyme problem is in the muscle glycogen phosphorylase, so they, whenever they will exercise, they will have pain. So on in resting stage, they will not have any pain. Okay, there will not be any hemolysis, but rhabdomyolysis, myoglobinuria, as Saurabh is saying, that is there. So look for exercise intolerance in questions when they want to make you the diagnosis of type 5 GSD, your McCall's disease. So M for M, muscle glycogen. Then you have a type 7, the Torrey's disease, where muscle and erythrocyte PFK is defective. Also look for exercise intolerance in them, but focus more in McCall's, Pompey's, and your von Gierke's and Corey's and Anderson. Let's move to the fructose metabolism now. Only the disorders we will take: galactosemia versus hereditary fructose intolerance. So, are you guys with me? One major thing which you are going to see here, like in the clinical feature, is their intellectual disability, convulsions, vomiting, jaundice. Now, the problem is fructose metabolism. So, look for if the condition is triggered by fruit juices. Okay, so if that is triggered by fruit juices, that condition is HFI, hereditary fructose intolerance. Now, fruit juices, any baby won't be taking fruit juices right away. So we will try to wean off the baby after 6 months, and this is the age of presentation which is giving. So in case of hereditary fructose intolerance, the aldolase B enzyme is defected, and the problem happens mostly in the babies who are of age more than 6 months. So once the mother starts to introduce fruits to the baby, that time these patients presents to emergency. So clinical features will be same for both of the conditions. So you look for the triggers, and if the baby is still breastfeeding first week of life, then that will be galactosemia. Okay, so that is going to help you with the differential diagnosis. Then we move to the HMP shunt pathway. Again, we don't have to remember the whole pathway or cycle. Only important thing is the rate limiting enzyme of HMP shunt pathway. And the glutathione reductase, as I have told you several couple of times, that NADPH is required. So from where we get this NADPH, HMP shunt pathway is going to produce NADPH. This NADPH is going to be the coenzyme for the glutathione reductase enzyme, and this helps to maintain glutathione in reduced state. So we want it to be in the reduced state because of multiple reasons. Why? Because this prevents lysis of RBCs, maintains transparency of lens. Okay, so that is the main role. And why we have been discussing this? Because to understand very important condition which has been asked, that your glucose 6 phosphate deficiency, so glucose 6 phosphate dehydrogenase enzyme, this rate limiting enzyme of HMP shunt pathway, whenever it is deficient, and it is a X-linked recessive disorders, okay, G6PD deficiency. Now I'm expecting all those comments in the comment section, because I know that everyone knows about G6PD deficiency. This is the most common enzyme deficiency, and because this enzyme is deficient, HMP shunt pathway will not be working. If HMP shunt pathway will not work, NADPH will not be produced. So glutathione reductase will not be able to function. This is going to lead to the rupture of RBCs, hemolysis. As I have told you, that your glutathione reductase helps in the maintenance of RBCs membrane. Now, this is not there. That is why hemolysis is going to occur, which is going to lead to anemia, jaundice, and methemoglobinemia, and this is going to present as cyanosis. Bite cells, that's what I was expecting. Okay, so you can see the bite cells and Heinz bodies. And what is rule is, this is a protective against Plasmodium falciparum. So already hemolysis is happening, so that is why it is protective. What is the aggravating factor? Drugs and fava beans infections, etc. Now we move to the questions. 25-year-old male with chills, fever, malaise, and diagnosed with malaria caused by Plasmodium vivax. He gives a history of hemolytic anemia among the male members. See, X-linked recessive disorders happens in which kind of people? The males of the family. Okay, which of the following needs to be checked before starting anti-malarial treatment in this patient? Yes, Rebel, absolutely, because this is the case of G6PD deficiency, and this male is pointing you towards the X-linked disorder and Plasmodium vivax. These are all helping you to make the diagnosis, because we just read that, uh, you know, this is happened to be the protective factor against it. So they are trying to link it with this. then then I hope you can do a few questions yourself. I would like to move to the lipids. They have started asking a lot of questions on this as well, so let's focus on some classifications and then we move on to the next part. So lipids, we have essential fatty acids, omega 3 and omega C. I've just taken a little bit which is only important for exams. Okay, so anyone who's having a fear of missing out on important things, you don't have to be fearful, because you have to just read this PDF. That will be sufficient for your exam. So essential, L is going to remind you of linoleic and linolenic acid. Okay, so these two are the essential fatty acids. Again, essential means you have to take it into the diet, and if there happens a deficiency of essential fatty acid, then the conditions will be acanthosis, follicular hyperkeratosis. Why? Because vitamin, the fat soluble vitamins will be affected. The absorption will be affected. That is why it is going to cause problems. This you have to ask on the group MBBS 8981. Follicular hyperkeratosis, again with the same reason. Then we have a fatty liver and mitochondrial membrane damage. These are the features of essential fatty acid deficiencies. You have to take it from the diet. Now, omega 3 is important. Remember walnut is because it is rich in omega 3. So, omega 3, alpha linolenic acid, and this alpha linolenic acid you can have from flaxseed oil. Okay, for omega 3, 3 is, you remember, act, a 3-letter word. Act, from A you have alpha linolenic acid, from C you have a cervonic acid, and from T you have a timnodonic acid, to remember. Then cervonic acid is present in your breast milk, fish, and algal oil. So this cervonic acid is also called as DHA, docosahexaenoic acid. And why it is important? specifically important because of the infant brain development. And that is why we say that breastfeeding is important, because mother's milk is rich in cervonic acid. So it can also cross placenta. And if there is a deficiency of DHA, retinitis pigmentosa can occur. And what is the significance of omega 3 fatty acid? It decreases risk of atherosclerosis. Okay. Basically, all the cardiovascular events. So this decreases the risk of cardiovascular events. So we always should take that in diet, the omega 3 fatty acids. I hope you're all with me. Then the platelet aggregation, if there is risk of degenerative disease, if you have enough of omega 3 acid, you will not have mental illnesses, degenerative diseases will not occur, inflammation will not happen in you. So you should always take them in your diet. And this is also important for infant brain development, as I have told you. So this also benefits in your type 2 diabetes mellitus. So all of anyone who has diabetes patients in your house, you recommend them having omega 3 fatty acids. Okay. And ADHD patients, if you have, you recommend them for that. And NAFLD, which is an upcoming thing, non-alcoholic fatty liver disease. Okay, so everyone is also having fatty liver disease these days. Then we have last to discuss the omega 6 fatty acid, linolenic acid, arachidonic acid, and gamma linolenic acid. You remember it like a GLA or lag, whatever you want to remember as mnemonic. So these are also rich in, these are the omega 3 6 fatty acids. Sorry. Then these days, hot favorite topic is phospholipids, and I have already marked which is important for you to remember. One is phosphatidylserine, inositol also you can remember, okay, and the cardiolipin. Now, lecithin sphingomyelin ratio, I hope that all of you are aware of. So the glycerophospholipid, first one is your phosphatidic acid, okay. So this is present in your cell membrane. More important for you is to remember your lecithin, because it is acting like a lung surfactant. This lecithin is actually the phosphatidic acid plus choline. Okay, so you can see diacylglycerol plus phosphate in it, and to it there is a choline group which is attached. So that is why lecithin is also called as phosphatidylcholine. So this is acting like a lung surfactant. So it's very important for babies. So babies with the lecithin deficiency will land up into something called as respiratory distress syndrome. Okay, so that is where it is important. Then we have third one, which is your cardiolipin, and this is present in the inner mitochondrial membrane. Okay, this is associated with Barth syndrome, and also related to the false positive test of Treponema pallidum. So I will just suggest you to learn these very short, crisp points about cardiolipin. Then phosphatidylserine, important, has been asked, has a role in apoptosis. So usually phosphatidylserine, if this is the cell membrane and this black color represents the phosphatidylserine, this is present inside the cell, so in the inner membrane. Okay, what happens whenever a cell wants to signal that I want to die because of programmed cell death, apoptosis, the flipping occurs, and this phosphatidylserine is then expressed on the outside. So when it is expressed outside, it gives the signal for apoptosis. So this has a role in apoptosis. That's what you have to remember. And phosphatidylinositol is, you have to remember about it as the second messenger. Okay, so this is important for you with regards to phosphatidylinositol. So this act as second messenger in hormonal pathways. uh, Next, we move to the sphingospholipids. Sphingospholipids, they, all of you, I hope you know that they make up the myelin sheath of the neurons. They are present in the white matter of brain. And the LS ratio, lecithin sphingomyelin ratio, which is important for the lung surfactant function. Okay, anyone who can tell me the normal LS ratio? I'll be waiting in the comment section while I take you to the important glycosphingolipids. Just try to remember cerebroside, the galactocerebroside and glucocerebroside. Galacto is present in the neural tissues, and gluco is, yes, Dr. Expedition, absolutely right. Extraneural tissues, your glucocerebroside is present in there. Okay, then you have ganglioside. They won't be asking much about this, so just focus on cerebroside. Next, we move on to the disorders, which is more important than the sphingolipids itself. So, ideally, what is happening? The degradation should happen of sphingosine compounds. Okay, if there is a defective degeneration, you can find the PDF on Telegram. Then this will accumulate in the lysosomes. Okay, so therefore, it is going to be called as lysosomal storage disorder. Now, your first one, let's move on to the first one, GM1 gangliosidosis. This is autosomal recessive, right? So this is autosomal recessive. Please remember the enzyme related to it, the beta galactosidase. I want a little bit of focus from you all because this is a very important previously asked topic, and I hope you can help me to learn a lot of things in this particular topic. Okay, so the GM1 gangliosidosis, there will be frontal bossing in the baby, which you can see, and long philtrum, very difficult to identify from this. Low set ears, if you can see, normally it's not that low. Okay, and a cherry red spot on macula, dash with cherry red. I don't know what you're writing. So these are all features of it, and beta galactosidase is the enzyme defect. Then your favorite, Tay-Sachs diseases, Tay-Sachs disease, which is the part of GM2 gangliosidosis. Your beta hexosaminidase A is deficient in this. So remember A of Tay, and you can think of hexosaminidase A. So mostly when the exam says question, yeah, Niemann pick, we will study it later on. Hexosaminidase A is defected. In Sandhoff's, S is going to remind of you second. Second is like for two things. Two enzymes, A and B, both kinds of hexosaminidases. Hexosaminidase A is deficient, B is deficient. So what will be the symptoms? Developmental delay, muscular weakness, okay, and visual disturbances. Please see this, that there will not be any hepatosplenomegaly in them. So that's where you have to put a little more focus on. Then you have a Krabbe's disease. So your two B's, okay, so beta galactosidase is defective, or galactocerebrosidase. So you have to learn this table a day before exam, because again this can make you confused, and your globoid cell is seen in your Krabbe's disease. There will be opisthotonous posture in Krabbe's disease, which you can see. That's all about the Krabbe's disease, and developmental delay will also be seen. Right, then very famous, all of you can remember the Gaucher's disease, the crumpled tissue. This you can see the Gaucher cell, okay, crumpled tissue paper appearance. Then the enzyme defect, the beta glucocerebrosidase is the enzyme defective. Okay, and please remember the enzymes carefully, because they sometimes just give you the question and expect you to answer the enzyme defect. Yes, Saurabh. Let me at least reach to Niemann-Pick disease. Okay, so massive hepatosplenomegaly will be seen in them. Please focus on this. There will not be any mental retardation or CR spot. And there is this Erlenmeyer-Flass deformity, which is a little important here. Okay, they can also add on this, and this massive hepatosplenomegaly can be seen in them. Then Niemann-Pick disease. So you pick the bowl and spin it. So sphingomyelinase enzyme is defected here. Okay. And that's how you can remember the enzyme defect. Zebra body inclusions are very famous for Niemann-Pick disease, and there will be developmental delay in them as well. Then we have a Farber's disease. Mostly they have always been focusing on the enzyme defects in these disorders. So please read them carefully. So Farber, ER of Farber is going to make you remember ceramide, CER. Okay, ceramidase enzyme deficiency. So when you sit in exam, you look for these words. Okay, resembles rheumatoid arthritis. Then we have Fabry's disease. Fabry's disease is X-linked recessive. The enzyme defective here is alpha galactosidase, GALA. Okay, so alpha galactosidase is the enzyme. The features are angiokeratoma. There will not be any cherry red spot or no mental retardation, which can be seen in them, but there will be lenticular opacities which can be seen. Then another feature is urinary sediments in Fabry's disease. They have a Maltese cross appearance. Then, just for metachromatic leukodystrophy, remember about the enzyme. You don't have to remember any features. Okay, I hope we are good with this. Let us move to the metabolism part of the lipids. So, we have discussed it already. Fasting, the the hormone of fasting stage is glucagon, and I will give you this that insulin inhibits glucagon, but what doesn't inhibit is glucagon. Sorry, inhibits hormone sensitive lipase. Okay, but glucagon doesn't inhibit it. So glucagon is going to stimulate hormone sensitive lipase. So whenever we are fasting, I hope I'm audible to all. Whenever we are fasting, the glucagon is going to stimulate hormone sensitive lipase. Now, this hormone sensitive lipase is going to break down the fats which are stored in the adipose tissue, the triacylglycerides. And what are the activators of HSL? You can see glucagon. Okay, insulin is the inhibitor. So, insulin resistance. Now, what is going to happen? Whenever there is insulin resistance, insulin is not going to function. So, HSL is going to be activated, which is going to release free fatty acids in blood. So, this is the reason in case of diabetes mellitus, people have free fatty acids in blood, and these free fatty acids tend to be atherosclerotic, leading to increased risk of cardiovascular diseases. Uh, yes, Dr. Expedition, the way you want to remember it like that, but I simply can remember I for I. Okay, I inhibits, and the glucagon is the reverse of insulin. Okay, so regarding niacin treatment of hypertriglyceridemia, we have already discussed that it is also going to inhibit the HSL hormone sensitive lipase. Okay, so you remember more importantly glucagon, thyroxine. Okay, that is all for hormone sensitive lipase, the activators and inhibitors. This metabolic fuel we have already discussed, the hepatic glycogenolysis in early fasting stage, 16 to 48 hours of starvation. We have discussed gluconeogenesis, and ATP is coming from the beta oxidation of fatty acids. And in case of prolonged fasting, ketone bodies will be synthesized. Okay, so this alignment is a little bit disturbed, but I hope you can remember, and you from the previously discussed session, that acetyl CoA will be gone for the uh, ketone bodies formation in case of prolonged fasting, right? So as we discussed, beta oxidation of fatty acid, you don't have to remember the whole pathway. That's nobody's going to ask you. Where does it occur? It occurs in liver, skeletal muscles, and adipose tissue inside mitochondria. The site is important, which we have seen in the table as well. Then why it is important, the beta oxidation or any alpha. So fatty acids can also go in alpha or gamma oxidation as well. Apart from beta oxidation is important to synthesize the acetyl CoA. So whenever beta oxidation occurs, acetyl CoA is formed. This acetyl CoA can be used further for ketone body synthesis as well. But there is also alpha and gamma oxidation. So now these days they have started asking questions on the disorders of fatty acids. So that is why I have taken this. So medium chain acyl coenzyme A dehydrogenase deficiency, this causes sudden infant death syndrome. Now, why this happens? You see that this medium chain fatty acids, this enzyme is important for the beta oxidation. Now, if this enzyme MCAD, which is medium chain acyl coenzyme A dehydrogenase, is deficient, beta oxidation will be affected. If beta oxidation will not be there, no acetyl CoA will be formed or reduced acetyl CoA will be formed. So if this is going to happen, there will not be any formation of ketone bodies. Now, when starvation is there, you need ketone bodies, but in them, there will not be occurring ketone bodies formation. Now, this beta oxidation is not happening. Now, these fatty acids can go into omega oxidation, which is going to lead to the formation of dicarboxylic acid. Fine. Apart from this, you know that beta oxidation is also important to provide ATP for your glycogenolysis as well, gluconeogenesis as well. Then this is not going to release ATP. That is why they will have fasting hypoglycemia. So look for fasting hypoglycemia. So in them, the questions they will give you the history of fasting hypoglycemia as well. I hope this is clear to you. We will also discuss a question shortly after this, so that will become more clear for you all. Then we have a Jamaican vomiting sickness. This happens because of the unripe ackee fruit. So this is one of a fruit, ackee fruit, which is which has hypoglycine. So this hypoglycine inhibits acyl CoA dehydrogenase. Again, this is the enzyme which is going to lead to the deficiency of this is going to inhibit acyl CoA dehydrogenase. Therefore, beta oxidation will not happen. If this is not going to happen, the acetyl CoA will not be formed and gluconeogenesis will not be occurring. So again, the patient will land up into fasting hypoglycemia. Okay. So in both of them, because acetyl CoA is not formed, ketone bodies will be absent. So we can something do Rothera's test, which will be negative again. Then we have Refsum's disease. Refsum disease, look for a patient with ichthyosis, the baby, and retinitis pigmentosa. The enzyme which is defective is phytonyl coenzyme A oxidase. And this aggravates on consumption of milk or curd. So look for these, and the patients will be having cardiac arrhythmias and peripheral neuropathy. Then Zellweger syndrome, I hope you all know about it already. This very famous question. Paroxysm targeting sequence defect is there. So there will be a defective phytanic acid and very long chain fatty acid oxidation. So the features of Zellweger syndrome will be similar to a Down syndrome baby, but it is a little different. So you can just see all the features and listed here. Okay, so let's focus on the questions. I told you that they have started asking it lately. A 3-year-old infant is rushed to the emergency room with lethargy, vomiting, convulsions, and poor feeding following a period of prolonged fasting. Okay, so in fasting, this enzyme is not going to work. So laboratory results revealed hypoglycemia. Okay, these topics are important for you because these are all previous year questions. So you have to focus on them. Low ketone bodies, mild hepatosplenomegaly. What is the answer, Saurabh? We just discussed it now, the MCAD enzyme. See, you can't answer von Gierke's for every question. They have prolonged fasting. Look for this low ketone bodies. Why they have given this? Dr. Nova is saying MCAD deficiency, medium chain acyl CoA dehydrogenase deficiency. And this was asked previously. And that is why I'm telling you earlier they did not used to ask these questions, but they have started. This is a new pattern of exam. So look for this, no ketone bodies, because beta oxidation is not happening. Beta oxidation is not happening. That is why no acetyl CoA is produced and there will not be any ketone bodies will be synthesized. Okay. Then we discuss about lipoprotein metabolism. Anyone who can answer this question? Which enzyme is responsible for removal of triglycerides from chylomicron? Ramchandra Suthar is the answer for MCAT. We already discussed about the first question. Now I'm discussing lipoprotein metabolism question. Anyone who can answer this? Yes, this is lipoprotein lipase. Dr. Nova correctly answered. So again, this is a new thing which they have started asking. So I will just quickly explain you how the lipoproteins are metabolized in the body. Now, what happens? The chylomicron is responsible for the lipoproteins which are coming. Basically, this chylomicron is responsible for the dietary fat and cholesterol uptake. You, you ate lipids, they came in intestine, and your chylomicron just came there and took this triglyceride, and ApoB48 apolipoprotein was important here. Now what happens whenever this is uptaken and HDL gave it ApoC2 and ApoE? So ApoC2 and ApoE, this nascent chylomicron now turned into a mature chylomicron. Now this C2 is important. Why? Because C2 is going to stimulate what? Lipoprotein lipase enzyme. So whatever triglyceride chylomicron has brought until now, this lipase enzyme is going to break that triglyceride and going to give it to the adipocytes for storage. Okay, so this is the question which they asked on lipoprotein lipase. This ApoC2 was responsible for the activation of lipoprotein lipase, and chylomicron gave the triglyceride to adipocyte. So that was the question they asked. Removal of triglyceride from chylomicron, which is the enzyme. Lipoprotein lipase is the enzyme responsible. Then, after giving off the triglyceride, this becomes the remnant chylomicron. Okay, so this becomes the remnant chylomicron, and further from liver. So as I told you, this chylomicron is dealing with the exogenous triglyceride transport. Okay. Now we have a VLDL, very low density lipoprotein. This uptakes the triglycerides from the liver, as you can see. Now this HDL again is giving C2. So the same story will be repeated. This is going to induce the lipoprotein lipase and VLDL, and this is also going to give off its triglyceride content to the adipocytes. Now, in this meantime, after giving off this triglyceride, this is getting converted to the intermediate density lipoprotein IDL. Okay, this is again uptaken by the hepatic cells, okay, which is receptor mediated endocytosis. You don't have to go into the details of it. Then, in the end, what is going to happen? It is going to go into formation of LDL. Now, this low density lipoprotein, this is also called as bad cholesterol. What is the reason of calling it as bad cholesterol? Because it is going to give off its 70% of the triglyceride to the liver. If it is giving to liver, no issues, because liver can break it down and excrete it in the form of bile. But what happens here is the 30% of it is going to the peripheral cell from the LDL, and this is leading to the formation of atherosclerotic plaques as well. So this is going to be the major cause of cardiovascular diseases. Okay, so that is the reason why we call it as LDL, as a bad cholesterol. Then we have HDL, which is called as good cholesterol. Why? Because good cholesterol, it is called as good cholesterol because it is involved in the reverse transport of triglyceride, okay, with the enzyme LCAT. So if they had asked previously about chylomicrons, they can ask HDL LCAT enzyme. Okay, so this is something which I want you to remember. Now the disorders related to lipoprotein is important. Familial chylomicronemia, which is your type 1 disease. This is hyper autosomal recessive. Okay, and what is defective here? ApoC2 is defective. We just read about C2, remember? So if this is defective, the major issue which is going to happen is in the chylomicron, which is going to accumulate, because we just discussed when to the nascent chylomicron C2 was getting attached, it turned into a mature chylomicron. So now this is accumulated chylomicron, and VLDL also had a similar pathway. So what is the major content of chylomicron? It is triglycerides. So triglycerides will be elevated, but cholesterol remains normal. So now this is a hypertriglyceridemia is there. This will lead to the eruptive xanthomas, which you can see. And if you take up the blood sample of this patient, they will have milky white plasma because of the lipemia, and they can have, fat deposition in their retina as well. Okay, xanthoma retinalis can also be there. Then we have familial hypercholesterolemia type 2, which is autosomal dominant. So remember it though, okay, though, which will remind you of type 2. So in this, 2 can still again remind you of receptor. Okay, so the defect is ApoB100 mutation. So because of this, what is affected is LDL. So remember everything like 2. This is type 2, receptor 2, and then ApoB100 2, and LDL 2. So cholesterol will be raised in them, but triglycerides are normal because LDL has more cholesterol. So because of LDL raise, cholesterol is gonna be high. So they will have a family history of cardiovascular diseases. As I told you, the LDL is the bad cholesterol because it is going to deposit all the cholesterol into the peripheral tissues. Okay, so very tandem xanthomas are very peculiar of this, specifically in the Achilles tendons, which is most common, and there will be a corneal arcuus, which you can see there is a ring of lipid which is formed in the cornea. Then we have familial beta lipoproteinemia, which is the type 3 hyperlipoproteinemia. This 3, you just flip this 3 with apoenzyme E. Okay, and this is an autosomal recessive one. So ApoE is going to actually deal with the remnant chylomicron. So this will be elevated, cholesterol will be elevated, and triacyl will be elevated. So if you remember 3 as 2 plus 1, then you can think from here triacyl glyceride and cholesterol. So both the things will be elevated. This is the mnemonic to remember, and the tuberoeruptive xanthomas will be there given in the question, probably like an image or something, and they have Palmer xanthomas as well. Cytosterolemia or type 2 is a mutation of ABCG5 or G8. They have not asked it, so it's not that important. Then we have Tanger's disease to read. So if you remember, we used to have a drink Tang. So when you were a children, you were learning ABCs and you used to drink Tang. Okay, so Tang is going to remind you of Tanger's disease. The ABCA1 is important, and this is actually related to HDL. I have not gone into the depth of HDL, but that's related to that. Cholesterol levels will be higher,
And these people have hepatosplenomegaly, which you can see, and orangish tonsils, which you will be seeing in them. Then we have A beta lipoproteinemia, the another lipoprotein disorder. So you can what happens in them is a transfer protein defect is occurring. So if the transporter is defective, all the lipoproteins are not going to be transported. So there will be less of everything. Chylomicron will be low, VLDL will be low. So look for this. This is different from others. This is not increase, but this is rather a decrease, and the patient will have a pigmentary retinopathy. Then we have partial LCAT deficiency, which is called as fish eye disease. Okay, I hope this is enough for you. Then we'll move on to, let's discuss about amino acids. I hope that you're all with me. We are just left with a little bit of portion. So I want you to stretch a little for this last 1.5 hour. Dr. Expedition, Saurabh, are you all here? Okay. So we have this first one, the classification of amino acids. Okay, so the aliphatic ones are simple amino acids. So remember it as like gas, G for glycine, alanine, and S for simple. Then when we have a tree has a branch, okay, and branch has leaves on it. So you remember this as LIV, leaves of the branch, leucine, isoleucine, and valine. And the OH group containing, hydroxyl group containing amino acids, we have serine, threonine, and tyrosine. So the mnemonic to remember is this, the Siri of Apple. So the when Siri gets tired, Siri gets tired. So tyrosine, it's tries, threonine, alcohol, OH group. Okay, so that's how you can remember. Then you have methionine. Remember it like methi ki sabzi. Cysteine is for sabzi. They are all sulfur containing amino acids. So whatever, if you have your own mnemonics, you can use them as well, as some of you are actually answering. Acidic amino acids, you can just simply remember because the name itself has acid in it, aspartic acid and glutamic acid. And then you have amide containing ones, which is your asparagine and glutamine. Basic is the hal one, or histidine, arginine, and lysine are the basic amino acid. Histidine has been asked related to the buffer system, and aromatic amino acids are the ones with benzene ring, the tyrosine, tryptophan, okay, and phenylalanine. These are the aromatic ones. Amino acids, which is your proline. Okay, that is about the classification based on side chain. So amino acid they have asked sometimes, so that's why this becomes a little more important for you to remember. Then the polar amino acid, the one with the charge. So A is for acidic, B is for basic, and C is for charge. So all the acidic and basic amino acids are the polar one, and the uncharged ones are the amides with hydroxyl group in its name, which is your serine and threonine. Amides are the asparagine and glutamine. Simple, among simple, only glycine is uncharged, okay, because glycine is simple and it just have H in respect with in the place of your R group. Okay, so this is the structure of your glycine. So this is the simplest amino acid as well. Sulfur containing amino acid is your cysteine. And non-polar one, you have the branch chain amino acids in them, the aromatic ones, and the simple is your alanine in this, and methionine and proline, they are all your non-polar ones. Then this is little more important. Okay, so we have been saying about gluconeogenesis, and I told you that formation of glucose from non-carbohydrate products, substrates. So this one of the known carbohydrate substance can be amino acid. Which amino acid? The glucogenic ones. Okay. So the two L's are the ketogenic, leucine and lysine, and both ketogenic and glucogenic. Who's gonna produce both of the things? These are phenylalanine, isoleucine, tyrosine, and your tryptophan. Okay. Then you have remaining all, apart from all of these which we have discussed, are the glucogenic ones, which are going to be helping in gluconeogenesis. Then about structure of proteins, they don't ask direct questions on structure, but yeah, the primary structure is mainly formed by the peptide bond, which is a covalent type of a bond. Then we have a secondary structure, uh, which happens because of the coiling of the linear structure. So one amino acid connecting to the other amino acid, then other amino acid. This is the primary structure. Now the amino acid chain, if they are coiling among each other, going to form the secondary structure. Alpha helix, being the most common secondary structure, has intra-chain hydrogen bond. So whatever is highlighted holds utmost importance. This is disrupted by the proline. Okay, and glycine can help in bends, because glycine is going to very simple amino acid, no steric hindrance. So it is a very small amino acid, so that time it can bend the linear chain of amino acids. Then we have in beta chain. So beta has a E in itself. So this has interchain hydrogen bond, the beta sheets of secondary amine structure of proteins. Then we have a tertiary one, which is a 3D structure, can perform function, and it forms domains where enzymes can also, the active site of enzyme can be one of a domain. You don't have to understand that for your exam. Quaternary is having more than one polypeptide, the multiple amino acid chain that is going to interact and form quaternary structure. So these both, the tertiary and quaternary, do not have the covalent but the non covalent forces in them. So this is the structure which is given. This is tertiary, quaternary, primary, and secondary. This was asked in exam, the protein folding. So from protein, the primary structure, we get the secondary. From secondary, we get the tertiary, and from tertiary, the quaternary. So what happens is protein gets folded up. So whenever they get folded up, there is a specific group of protein which is called as auxiliary proteins, or the molecular chaperones. Okay, you don't have to remember all the names, but this word was asked, that molecular chaperones help in the folding of proteins. Now, if the protein folding is occurring normally, the way it should, then it is good. Otherwise, the body ideally degenerates or degrades the misfolded proteins. But what happens is that sometimes the body is unable to degrade these misfolded proteins. That leads to protein misfolding diseases. Yeah, the essential amino acid, PBT, Tim Hall. I guess all of you remember this. So I can let you revise automatically. Essential amino acids and non-essential. Essential, which you have to take from your diet. Okay, so uh, T, V, Mill, Path is the mnemonic, or some of you remember at Met will fly, PVT, Tim Hall, anything you want to remember. And then we have non-essential ones, the remaining others. Two being the semi-essential. This is something which everyone knows, but they ask more related to the uh, questions related to the clinical cases these days. So prion related diseases, you read it in pathology as well. Alzheimer's diseases. So don't forget to remember from there all the protein which is misfolded in Alzheimer's. Okay. So these are the diseases which are enlisted here. You can read them. Then we have protein degradation. Now, ideally, I told you that protein has to be degraded if it is misfolded. But if it doesn't, then it leads to problem. So there has to be some pathway for their degradation as well. So, what is that pathway? Proteasomal pathway or lysosomal. So, for lysosomal pathway, we do not need to have any ATP requirements. But proteasomal pathway, we need ATP, and there is a compound which is called as ubiquitin that is required. So whenever a protein, ubiquitin acts like a tag. If a ubiquitin tag is attached to that protein, it is going to definitely go into the degradation part. Okay, so for all these, we have a proteasomal degradation. Now, this is the more important part. You can not miss this before your exam, the collagen. Okay, so collagen, we have three polyproline structure, alpha chain. So one is the alpha chain of collagen. Then what happens? This alpha chain, three alpha chains combines and forms the triple helix, the three alpha chain structure, and then we have a quarter staggered arrangement of collagen. Collagen is the most abundant protein of the body. Okay, and polyproline alpha chain has a glycine XY repeat. Now, this we have discussed hydroxylation of proline and lysine, which happens because of vitamin C, and the enzymes involved are prolyl and lysyl hydroxylase. Okay, so this helps in the triple helix formation, and it occurs in the rough endoplasmic reticulum of the fibroblasts. And what is formed after this triple helix? A pro-collagen is formed. Then what happens if this is one triple helix? Let's say if this is another triple helix and this is the third triple helix. So each triple helix is uh, formed after one fourth, the quarter distance apart from the next alpha helix. And there are some cross links which are getting formed in all of that. So this is the quarter staggered arrangement of the collagen triple helix. And this needs your copper. Okay, that's what we discussed earlier. So this is the place where copper is required and the enzyme lysyl oxidase is required. So for covalent cross links. So again, I will tell you this is important. This is important. What is formed here? Tropocollagen is formed and the enzyme is lysyl oxidase. So focus on the more important things. TV till 8 p.m. Yes, Saurabh, you can also remember it as TV till 8 p.m. Whatever you like. Then the type of collagen, this has been asked. The type 1 collagen is present in bone, 1 for bone. The diseases associated with is osteogenesis imperfecta and osteoporosis in adults and Ehlers-Danlos type 7. Okay, then cartilage, T is going to remember of U of 2, and cartilage is chondrodysplasia. Severe chondrodysplasias will be happening in this. Okay, if there is collagen, type 2 is deficient. Type 3, okay, 3, you flip the 3, make a E out of it, Ehlers-Danlos, but it is type 4, 3, 4. Okay, remember it like that because it was type 7 was because of 1, because from a 1 you can make a 7. Then the glomerular basement membrane, the type 4. So if you write basement membrane, base, type 4 is present in the glomerular basement membrane. And if it is deficient, the disease condition is Alport syndrome. Okay, so that's how you can remember. So these are the important, and then the 7, which is present in anchoring fibrils, epidermolysis bullosa. But I will ask you to remember about this, and this one. Okay, then we also discuss and study this fibrillin gene in pathology about the Marfan syndrome. This is the another protein which is mutated. The fibrillin 1 mutation leads to the Marfan syndrome. I hope you remember everything related to F, which is the chromosome which is affected. What chromosome? 15. Okay, that's how you can remember. And keratin, you know, that present in the skin, nails, hair, etc., which is rich in cysteine. Okay, and associated disorder, remember this is epidermolysis bullosa. So just remember the points, and now we move to the urea cycle. Okay, what happens in urea cycle? Why it is important? Because previously they asked this question. Subluxation of lens is also good. You can revise it later on. A question was asked. Let's move to the question. A 2-month old infant presents with difficulty feeding, vomiting, and lethargy. Okay, so this difficulty in feeding in neonates, vomiting, and lethargy is a feature where whenever urea gets accumulated, is going to be a general feature of all the neonates. Okay, so that's why it is important for us to read these defects now. So this is the urea cycle, and we can see, I don't want you to go into depth and learn all the pathways, but just focus on the enzymes, the CPS1, which is the rate limiting enzyme. So this CPS1, when this goes defective, you have a hyperammonemia type 1. Okay, so the type 1 hyperammonemia, this happens because of CPS1 enzyme defect. Okay, then we have OTC, which was asked in your exam as well, which is your hyperammonemia type 2. So T is going to make you remind of 2, and this is X-linked recessive. So again, the males will be affected. So this is the OTC. This is affected here. So this is your type 2. So in the exam, you can probably directly come here and revise this page. Okay. And then we have citrullinemia type 1, which is here, which is defective. Okay. So that's how you are supposed to just learn these. And again, because your ammonia is neurotoxic, okay, and this is, you don't have to remember from how the ammonia is formed, but proteins actually undergo reactions of deamination. So whenever the ammonia is produced, we have to manage it somehow. Okay, that's why we have a urea cycle. But sometimes when there is a defect in different enzymes of urea cycle, we will have issues with these, and the neurotoxic symptoms will be produced. And last time, only in last exam, 2 questions were asked from this. That's why it becomes even more important for you to focus on this. Arginase defect is going to cause argininemia. So in this case, what is happening is spastic diplegia or scissoring of lower limb. So they can also giving you a image of this question. Then if ornithine transporter is affected, then what is going to happen? The carbamoyl phosphate, which is shown in the reaction, is going to combine with lysine because it will not be able to find the ornithine, which will lead to homocitrulline, uh, increase in homocitrulline and homocitrullinemia. So this OTC is called as HHH syndrome because of homocitrullinemia, hyperammonemia, and hyperornithinemia. So this is a defect of ornithine transporter. Okay, so focus on more important ones, and you will be good for your exam. So can you all answer this question now? A 2-month old infant presents with difficulty feeding, vomiting. Already they are saying it is a hyperammonemia. Okay, the lab test is revealing hyperammonemia, and high levels of orotic acid in the urine is seen. The probable enzyme defect is here. Come back and just see. Anyone who can answer this? This is OTC deficiency, which we have discussed. Now, this again another question they asked in the same exam, which is telling about hyperammonemia, homocitrullinemia, and hyperornithinemia. Okay, so this is triple H, and triple H I said to you is ornithine. So H ornithine transporter goes defective. So that's how you can remember about this. Come on, we just have to push the class for a little bit, and now the more important topics are coming up, so please focus a little more here. The metabolism and disorders of phenylalanine and tyrosine. Are you all with me? I hope you have understood the question. The phenylalanine. Phenylalanine gets converted to tyrosine. What is the enzyme required here? Because a defect leading to this enzyme deficiency is also very important. Yes, Dr. Expedition, can you also tell the full form of this name, enzyme? Phenylalanine getting converted to tyrosine. This is also written here. Okay, so this tyrosine is going to then go into two pathways. Either it is going to go into the catabolic pathway and anabolic pathway, where it can form melanin, catecholamines, and thyroid hormone synthesis can occur. Okay, so we have discussed this already. uh, Tetrahydrobiopterin is required for the functioning of this enzyme, phenylalanine hydroxylase, and NADPH is also required. So, phenylalanine gets converted into tyrosine with this enzyme. So, this is the whole pathway. Now, again, this homogentisate oxidase is important. If this goes defective, what is the condition we can have? I need your participation. Can you all answer? So in the catabolic pathway, first is this phenylalanine hydroxylase enzyme, which is important, and second is homogentisate oxidase, which is important. Yes, absolutely. So Dr. Expedition has come up with the right answers. So based on this, we have disorders. The classic phenylketonuria, where the phenylalanine hydroxylase goes defective. If phenylalanine hydroxylase goes defective, your phenylalanine will not be able to convert into tyrosine. Okay. So if that is not going to happen, what is going to happen? This cannot synthesize your neurotransmitters as well. Okay. So this is going to lead to disease, which is, you know, the patient will not have catecholamines because tyrosine is going to not form the catecholamines. Melanin is not synthesized, and that will lead to hypopigmentation. And because catecholamines are not there, thyroid hormones are not synthesized, agitation, hyperactivity, and mental retardation, because your thyroid hormones are very important for mental development. Okay, so intractable vomiting, these are all features of classic phenylketonuria. So please, all of you, your attention is required because these are very important for exams. The non-classic phenylketonuria has been asked previously. Uh, this is the enzyme defective, and only the enzyme defect is enough for you. And L-captonuria is where we just have to remember the homogentisate oxidase enzyme. And what is going to happen now? Uh, the Garrot's tetrad is important. Okay, the L-captonuria, this is part of that, and Pantosuria, albinism, and cystinuria. Which age it is present? In the middle age people. Okay, this is going to present with back pain as well, and your ochronosis and everything, the blackening of urine on standing. So this is a classical case which you all have earlier studied, so I won't take it in much of detail. Okay, and I believe that these are more important for you to read in the disorders of phenylalanine metabolism. Okay, so these are the images. They can also give you the enzyme, which is your ochronosis. Okay, and this is blackening, black discoloration of urine, which is happening because which enzyme is defective? Tell me the enzyme defect for your revision. Rebel, Ritik Kumar. Anyone who can tell me the enzyme defect? Now the Tyrosine is going to form the dopa, dopamine, epinephrine, and norepinephrine, all the catecholamines, which we have already discussed. Okay, so in this relation, there is a disease which is pheochromocytoma, right? Yes, Dr. Expedition phenylalanine hydroxylase. So keep revising also along with the class. Pheochromocytoma is a tumor of what? Can anyone tell? So the patient will have worst headache of his lifetime. Okay, in case of pheochromocytoma. So uh, this is something which you also read in adrenal glands. Okay, you also read it in surgery. Fine. Then, as we discussed, that tyrosine is also going to help in the synthesis of melanin. So, if that goes defective, a condition which is called as albinism, where the enzyme tyrosine goes defective, and the patient will be having milky white skin and hair. So, just little bit of information is enough for you. Okay, then your tryptophan is going to form which amino acid? Niacin. That's what we have already discussed. And I told you that we just read in vitamins about QPRTase enzyme. So I told you that this is related to vitamin B6 deficiency, and that is going to come into amino acid deficiency. Sorry, amino acid metabolism. Okay, so that is all about this, and you don't have to remember the dosage. Then we have all the derivatives of tryptophan, which is also melatonin. So in the end of this slide, I have made a table for you to whichever precursor is important, you can remember from that table itself. Okay, Hartnupp's disease, which we have already discussed. Carcinoid syndrome was also discussed with vitamin. That much is already important, because this pathway will be distributed. In the carcinoid syndrome, the argentrophin cells goes on, replicating. So every serotonin will be formed from the tryptophan, but the niacin part will be compromised because of that. Okay, so that is something which we have already discussed. Okay, so I don't want to repeat it because we already have discussed in vitamins. Okay, then what is important for you? Are you all listening to the class? The homocystinuria. Let's discuss this, the Marfan syndrome like condition. Dr. Expedition and all the students who are listening to the class, please let me know that you're participating in the class or not. Okay, so let's discuss on the more important features. Okay, the homocystinuria, there will be developmental delay, and if you can see the tall slender fingers and legs just like in Marfan syndrome, and ectopia lentis, but this is inferomedial ectopia lentis. On the other hand, in Marfan syndrome, what kind of ectopia lentis is seen? Can anyone tell? Because all other features you read in Marfan syndrome also. This is going to differentiate that. Superior and yeah, this will be enough because they ask questions. Wherever I have asked you to focus more, please focus more on that part, Shenavaz. Neat PG, you have to go probably in little more details, but that much is enough. Yes, superotemporal is the right answers. So in classic homocystinuria, the enzyme defective is cystathione beta synthase. Therefore, the defect in formation of cysteine occurs. Okay. So levels, you use it for diagnosis. So for FMG, you don't have to remember this. In non-classic homocysteinuria, methyl B12 formation occurs, and the enzyme is methylene THF reductase. Okay, so the defect which occurs is the remethylation of homocysteine to methionine. If you remember from our vitamins, so homocysteine gets converted to methionine, and this happens because of remethylation. Okay, so this is the defect in non-classic homocysteine urea. Okay, so in cysteinuria, what goes excreted? Your cysteine, ornithine, lysine, and arginine. All these amino acids, they get excreted in the urine, and these are the crystals which are seen in urine. Okay. Then we have another disease condition which is cystinosis, the defect in cysteine transporter in the lysosomes. Okay, so this actually is seen with renal failure, bone marrow suppression, but they don't ask many questions on this. Then we have glutathione, your tripeptide. This glutathione is a little hot favorite of this. At least remember that glutathione is having glutamic acid, cysteine, and glycine. So it is a tripeptide having 3 amino acid. So if you can see glutathione name, G is for G, so glycine and glutamic acid. So two are easy right away. Then you make a C out of a G and cysteine. So they can ask you what are all the 3 amino acids. Okay. Then we have functions of glutathione. We have discussed just a couple of times the glutathione peroxidase, okay, which is having antioxidation role. So only this much is important for you at your level, that glutathione helps in free radical scavenging. Just remember this much. Are you all listening to the class? This branch chain amino acid maple urine syrup disease, something which I can expect you to answer? Okay, so what happens in maple syrup urine disease? What is defected? The branch chain ketoacid dehydrogenase enzyme. Remember, we had discussed about this enzyme earlier. So this branch chain ketoacid dehydrogenase enzyme is defective. That is why the patient or the baby presents with difficulty, feeding difficulties, convulsions, and lethargy and coma. Okay, so burnt sugar order of urine is something which you have to uh, remember. Okay, so this is going to help you to make the diagnosis. The maple syrup urine disease, BCKD enzyme is defected, and the smell of the urine is burnt odor. Then, uh, apart from this, remember about the arginine, which is derivative of nitric oxide. Okay, basically it is a precursor of nitric oxide. So if there is a deficiency of arginine, nitric oxide will not be synthesized. So I will just focus on to the more important and previously asked questions right now, because already you can't remember everything, and what is more important, you should focus on that part only before your exams. Okay, then we have only these molecular biology, this topic they used to ask previously in exams, but these days they have stopped asking questions more on this, but they have been focusing more on lipoprotein metabolism, urea cycle. So vitamins is always has always been hot favorite and still is hot favorite topic. So this was a question which was asked a long time back. The RNA molecule contains the coding sequence 5-AACACC 3 if let's start molecular biology with these questions. What will be the corresponding DNA sequence in the template strand from which it was transcribed? If this is the template, then what will be the DNA sequence? Anyone who can tell this answer? Doctor Expedition. Yes, this is the answer. And I hope that you know that A bonds with T, G binds with C, and there will be three hydrogen bonds in them. And the Chargaff's rule, when purine are equal to the pyrimidine. So I won't focus more on molecular biology because they're not asking many questions these days. Okay. So just remember the more important things, that nucleosome, they are made up of these core histone proteins. And we move to the more important topics, which is Leach-Nyhan syndrome right away, and Kelly-Siegel Miller syndrome. Okay, so the defect in HGPRTase enzyme happens, and this is a self mutilation compulsive disorder. So you will be even given an image with, the child probably have eaten, bitten their own fingers, leading to bleeding in the nails, and this kind of image has been given. So this is the disorder of purine catabolism, and whenever purine are catabolized, uric acid was formed. Okay, so there is a lot of purine catabolism which is happening, so a lot of uric acid is also produced. So hyperuricemia is hence a feature, and neurological defect. This is a self mutilation behavior which is shown in them. And then we have a Kelly-Sieg-Miller syndrome, which is same enzyme defective, but it is a partial defect of the enzyme. And this is going to present just like the acute gout. You can see that there are uric acid crystals which are getting deposited in this and the tophi. And that is only important for you, because this much information can help you make the diagnosis. They don't go into the depth of this. Now, apart from this is one of the important topics which from where they're asking questions from molecular biology. So this is application based exam these days. They don't go and ask you the translation or transcription or the steps of translation transcription, but if some defect is happening and this is clinically relevant, that is the place where they focus more on. So in the defects in DNA, there, if pyrimidines get dimerized, okay, so pyrimidine should usually not combine with pyrimidine, but if it happens, the defect occurs. Usually there is a repair mechanism which is nucleotide excision repair which occurs, but if it fails to occur, the associated disorders with are xeroderma pigmentosum. Okay, so this has been asked, and they will give you probably a history of cutaneous photosensitivity, that the if the baby goes out in the sun, gets rashes, so that kind of a history of xeroderma pigmentosum will be given. Cocaine syndrome and trichothiodystrophy is another example of defect of nucleotide excision repair, but you focus more on xeroderma again, and then cocaine syndrome. Okay, so it is associated with the sunlight exposure. And then A basic size, which is base excision repair defect. This is MUT protein associated polyposis. More important among them is base mismatch defect. So if the bases mismatch, they have to be repaired actually in the body. If they fail to repair, the patient have Lynch syndrome, or also called as hereditary non-polyposis colorectal cancer. So they will not ask you a lot of detail about it. They will just give you the history, clinical features, and they will ask you which defect it is. So you have to probably answer it as a nucleotide excision repair defect or a mismatched repair defect. So Lunch syndrome, LM, M is for mismatch repair. Xeroderma pigmentosa can help you think of photosensitivity, can help think of you sun. So N will help you think of nucleotide excision repair. So that's where you should focus. Don't focus on more things, because that's going to lead to more confusion. Okay, then you have double strand breaks or single strand breaks, if there is happening, then again I'm telling you that focus on more important and only very basic points, because they don't go in depth of these questions. Severe combined immunodeficiency syndrome, that is uh, non-homologous end joining is going to happen. The defect is in the non-homologous end joining, this kind of defect. And ataxia telangiectasia, there is a homologous recombination defect which is going to happen, and in Bloom syndrome as well, and breast cancer as well. Okay, so that's these are the three disorders. Again, I'm telling you, they will give either the clinical features or the name of disorders, and they will just ask you what is the repair mechanism which is going defective in these disorders. So that's where they are going to focus. So that's why you don't have to remember a lot of information with regards to this table. So let's discuss one of a question which has been asked already. 46-year-old male was recently diagnosed with colorectal cancer after presenting with multiple polyps. Okay, so polyps, Rocky has already answered. Nucleotide excision repair, is it the right answer, Rocky? I told you two conditions, xeroderma pigmentosa. I told you this is important, and then HNPCC is important, right? Mismatch repair is the right answer, and I told you xeroderma pigmentosum will be related to sun exposure. Okay, sun will remind of you n you answer nucleotide excision repair for xeroderma pigmentosa, but question is pointing towards HNPCC. They have already given you the diagnosis, so HNPCC is going to remind you of what? Mismatch repair. Okay, this one, the Lynch syndrome, LM is going to remind you of mismatch repair. So that's all which is important. Then let's wrap up the session with the electron transport chain. They used to ask questions more from ETC earlier in comparison to these days. So, which of the following enzymes uses molecular oxygen as the hydrogen acceptor to produce water? So, we know about the, someone is saying a catalase is not at all right answer. What is the answer for this question? I'm expecting you people to answer. Ramchandra has come up with the right answer very quickly. Dr. Mahi has come up with the right answer, cytochrome C oxidase. So ETC is, I believe that all of you should be good already in ETC. So we have total of 5 complexes in electron transport chain. We have to remember about the names of them, and then we have to remember the inhibitors. That much will be enough for your exam. Okay. So the complex one, what is this electron transport chain? Basically, it's just going to transport electron from one complex to another complex, thereby just pumping of proton will be done after this, which is going to create a potential difference, and this potential difference in the end is going to release ATPs. Okay, so that's the main goal of electron transport chain, the synthesis of ATP. So the complex one is NADHQ oxidoreductase. Don't have to remember about how many protons it has pumped. The NADPH reductase, so one should remind you of rotenone, the inhibitors, and the amobarbital and pyridine A. A is also going to remind you of one, the first alphabet. Okay, so just remember this. Then you have complex 2, succinate. Okay, second alphabet. Succinate Q oxidoreductase is the name of the complex 2. And what are the inhibitors? The malonate and the carboxyl are the inhibitors. Now another is the complex 3, Complex 3 has Q cytochrome C oxidoreductase. So C is the complex 3 third alphabet. So this is going to be inhibited by antimycin A or BAL, okay, dimercaprol. So mycin, okay, so it is antimycin C is going to remember. So word 3 holds importance here if you want to remember it for long. Then we have type the complex 4, sorry, the cytochrome C oxidase. Okay, so the first one was Q cytochrome C oxidoreductase, and then we have a cytochrome C oxidase. Okay, this oxidase is going to be inhibited by the carbon monoxide, cyanide, or hydrogen sulfide. So these are the three inhibitors of complex 4 of the electron transport chain. Then in the end, we have complex 5, which is the last one which is used for ATP synthesis, the ATP synthase one, and this 5 is inhibited by etractyloside, oligomycin, or venturicidin. So these are all going to inhibit the complex 5. Okay, so uh, this is another question which is asked, but these disorders you also read in pediatrics, so I hope that you read from pediatrics. That will be enough, but anyone who can answer, a 2 week old infant presents with elevated conjugated, because we have not discussed heme metabolism, and that is an overlapping topic with the pediatrics also, so it's better you read it from there. Anyone who can answer this question? 2 week old infant presents with elevated conjugated bilirubin levels, dark urine, clay colored stools. The infant appears jaundiced but is feeding normally. Most of you are answering B. Please revise this a day before exam. Whatever I've told you to revise a day before exam, please do it, because you tend to forget those questions. Dr. Nova has come up with the right answer. It is biliary atresia. Okay, so I hope if you have you go and study little bit about your pediatrics part, and you will be good with this question. Okay, so the amino acid derivatives, we discussed phenylalanine, the enzyme PAH converts it into tyrosine. This tyrosine further goes to produce thyroxine, dopa, and this dopa goes to melanin production, dopamine, norepinephrine, and epinephrine. Okay, so SAM is the methyl donor here. So they have asked these kind of questions previously, that this is a precursor of what. So that is why I have given this table. Tryptophan synthesizes niacin, serotonin, we discussed it in a couple of times in a session. Histidine helps in carnosine, histamine. At least remember, histidine uh, synthesizes histamine. At least this much is important. Okay, then from glycine we have porphyrin, and it helps in the synthesis of heme. Arginine synthesizes it's used in creatine, urea, and nitric oxide. Nitric oxide, I told you earlier as well that it is important. And glutamate is a precursor for GABA and glutathione. So this is just a one liner question which still they can focus and ask. Fine. So uh, this is all about our session for today. And don't go in much of depth, okay, because whatsoever wherever the depth was required, I've already taken it. Molecular biology, they don't ask much these days, and the questions like ATGC, you all are aware of it. I hope you can calculate adenine, guanine also. Okay, so good luck for your exam. uh, Please focus on the things which I have asked you to focus on, because they are the most relevant topics and more frequently asked in the exams. Good luck. Good night.